हॅलो पूर्वा,
संतोष तुला ऐकू येतं का मी बोलतोय ते? संतोष
हॅलो.
आज इथे आलंय आता, मीटिंग इज ऑन स्ट्रीमिंग लाईव्ह ऑन युट्यूब.
ओके ओके पूर्वा, तू ऑन केलंस युट्यूब?
हो मी ऑन केलं, ऑन केलं.
ओके ग्रेट 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 ग्रेट. आणि तुला एक काय करायला लागेल अजून, ज्यावेळेस चालू होईल ना मीटिंग त्यावेळेस रेकॉर्डचं बटन दाबायला लागेल. ओके
करते.
चाल.
इथे आलंय बघा लाईव्ह ऑन युट्यूब.
येस 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 येस.
संतोष एकदा युट्यूब ऑन करून बघ एकदा.
बघतोय मी. येस आय कॅन सी.
मी ऑन केलंय सर, मी ऑन केलंय. आणि इथे लाईव्ह ऑन युट्यूब असं आलंय.
हो तुमच्या याच्यावर पण दिसतंय बघ.
दिसतंय का संतोष? पण ते युट्यूब चेक करून बघ तिकडे.
युट्यूब चेक केलं मी, दिसतंय तिकडे.
हा इथे लाईव्ह ऑन युट्यूब असं लिहून आलेलं आहे.
येस येस येस. इवन इट इज ऑन. युट्यूब वर पण ऑन आहे. दे जस्ट 10 सेकंड लॅग असतो, बट दॅट इज ओके, काही प्रॉब्लेम नाही. जो कंटिन्युअस युट्यूब बघतोय त्याला काही कन्फ्युजन नाही होणार.
हाय मकरन,
माझे हे बघा ना, स्क्रीन शेअर करू?
हा बघा ना एकदा, करा बघा सर.
हे दिसतंय आता संतोष?
हा सर दिसतंय.
स्क्रीन दिसते.
हा
स्क्रीन
स्क्रीनला काय इश्यू आहे?
नो 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 नो.
नाही. हा ठीक आहे, मग माझ्याकडनं काही होपफुली प्रॉब्लेम येऊ नये. ॲट माय
व्हॉइस पण क्लिअर आहे.
ओके
या
ठीक आहे, मग मी शेअरिंग बंद करतो.
येस सर.
चेक करू आता माझं. मकरन चेक केलं?
केलं झालं. हे काय
डॉक्टर राहुल तुमचं करा एकदा.
हा
सर तुमची स्क्रीन स्टॉप करायची नसतात.
अनिकेत सर
हा
येस.
फुल स्क्रीन कुठून करायचं?
स्लाइड शो खालून आहे, स्लाइड शो
किंवा F5
झालं की आपण
स्लाइड शो आणि तिथे
आलं दिसतंय आता?
येस येस परफेक्ट.
ऍक्च्युली एकदा का तुम्ही सगळे गेले की आपलं चहा पाणी. अगं नाही
सर म्यूट करा ना
एकदा
ओके, आई स्टॉप स्क्रीन स्कॅनिंग.
हा ओके.
समीर सर आलेत. समीर सरांना एकदा
शेअर करून बघितली सर आम्हाला.
सर्वांचं झालंय स्क्रीन शेअर.
आता फक्त हितेश सर राहिलेत. डॉक्टर हितेश हॅज टू कम हियर.
ओके,
I think he will join late. Dr. Rahul?
maybe.
Yeah, because.
Rahul, first program? तुझा? राहुल?
Yes, sir. बोला ना.
राहुल पहिला प्रोग्राम का?
सेकंड ऍक्च्युअली.
ओके. हा. मला पण लिंक पाठवत चल ना असेल तेव्हा.
ओके चालेल.
राहुल सर, आम्हाला ते हे कसं व्हायचं मी विचारलं होतं संतोषला, तर हे पाठवलं. वी कॅन बी असोसिएट मेंबर राईट?
येस.
फॉर्म पाठवून दे आम्हाला.
ओके.
कारण असे जास्त छोटे सीएमबी जास्त मजा असते ऐकायला.
ऍग्री.
जेन्युइनली रादर दॅन बिग.
ऍग्री.
इट्स मोर इंटरॅक्टिव्ह.
ह्यांची फोकस असते नेहमी.
दॅट इज ऑलवेज बेटर. आता सगळं लवाजमा असतं सगळं समटाइम्स.
संतोष सर, एक 4 PM ला मेसेज टाकूया का ग्रुपवर?
येस. एक 10 मिनिटांनी
रिजवान सरांनी टाकला.
ओके ग्रेट. माझा याचा पीसीच्या कनेक्टिव्हिटीचा काहीतरी इश्यू आहे. मी आता मोबाईलवर जॉईन केलाय. एक 5-10 मिनिटांमध्ये मी तिकडनं जॉईन करेल कॉम्प्युटरवर.
ओके ठीक आहे.
रिया ते दार उघडायला.
सचिन लोखंडे साहेब रेडी एकदम.
येस येस.
ऑल सेट.
ऑल सेट टू गो. मी पण मोबाईलवरून कनेक्ट होतोय. काही चॅट मध्ये क्वेश्चन आपण डायरेक्ट घेऊ शकतो याच्यावरती.
येस येस.
एक कुठलं तरी म्यूट करून ठेव, नाहीतर
हो. नाही करतो ना.
आणि अनिकेत सर, आम्हाला तुमची परत गरज लागणार आहे क्रिटिकल केअर ऑब्स्टेटिक्स साठी, HDU आणि ICU साठी.
हो हो, नक्की नक्की. तुम्ही सांगितलं होतं मला सर, कधीही सांगा. ऑलवेज रेडी टू हेल्प.
So tentatively we are planning in फेब्रुवारी मध्ये नेक्स्ट इयर मध्ये.
बरं.
फिजिकल झालं तर फिजिकल करू, नाहीतर ऑनलाईन करू.
नक्की सर, नक्की विल वर्क इट आउट. चांगलंच करू.
अनिकेत सर कुठे अटॅच्ड असतात?
हॅलो, भारती विद्यापीठला सर. भारती विद्यापीठ मेडिकल कॉलेज आणि हॉस्पिटल पुणे. आणि मग थोडे अजून 2-3 हॉस्पिटल आजूबाजूला व्हिजिटिंग कन्सल्टंट म्हणून आहे.
ॲज अ इंटेन्सिव्हिस्ट?
ऑब्स्टेटिक इंटेन्सिव्हिस्ट.
म्हणजे तसं नाही, मी सर ऑब्स्टेटिशियनच आहे आणि माझी फेलोशिप आहे हाय रिस्क प्रेग्नन्सी अँड क्रिटिकल केअर ऑब्स्टेटिक्सची, जी भारती विद्यापीठची फेलोशिप आहे.
कुठनं केली फेलोशिप? कुठनं केली?
आमच्या युनिव्हर्सिटीच आहे फेलोशिप सर. भारती विद्यापीठ युनिव्हर्सिटीची फेलोशिप आहे ती.
ओके.
आणि मी अटॅच भारती मेडिकल कॉलेजला आहे ॲज प्रोफेसर. आणि आमच्या इथे एक 6 पिरियड डेडिकेटेड ऑब्स्टेटिक HDU आहे, ते मी म्हणजे ऑलमोस्ट ॲज गुड ॲज लीड करतो. आणि मग बाकीचे आजूबाजूला जे आहेत मल्टी स्पेशालिटी हॉस्पिटल, त्यांच्याकडे थोडंसं ICU HDU बॅकअप आहे, मग त्यांचे हाय रिस्क पेशंट आम्ही तिथं मॅनेज करतो.
अरे वा, व्हेरी नाईस.
ते असतील तर मग भारतीचं कसं होतं, स्ट्रॉंग बॅकअप आहे ICUचा किंवा ह्याचा, त्यामुळे काही लागलं तर तिथं असतो. असं चालू आहे.
मी करतो हाय रिस्क केसेस गोदरेजला आणि मग कधी कधी फोर्टिसला. आणि म्हणून मी लास्ट 2 वर्ष AICUG ला ते हाय रिस्कच अटेंड करत गेलोय. आय विल नाउ कीप इन टच विथ यू इफ आय रिक्वायर एनी हेल्प.
हो सर, नक्की.
आणि डिपार्टमेंट जर वाढवता आलं तर आय विल गेट इनपुट्स.
हो सर, अगदी.
गोदरेजला कोविड पेशंट घेत आहेत?
इथं पेशंट इज रजिस्टर्ड तर मी करतो. म्हणजे मी ते एक मध्ये त्यांना एक नवीन CEO आले, त्यांचं परमिशन घेऊन श्रुतिकाची एक पेशंट होती, श्रुतिका ठक्करची, ती केली. मला वाटलं होईल आरामात नॉर्मल, पण ती त्रास देऊन नॉर्मल झाली आणि त्यानंतर मला बरोबर 4 दिवसांनी कोविड झाला. दो आय वॉज वॅक्सिनेटेड विथ ऑल द प्रिकॉशन्स, बट इट वॉज ओके. इट वॉज नॉट अ व्हेरी मेजर डिसीज फॉर मी, जस्ट नेमसेक इन्फेक्शन. Today only I had gone to help one of the colleagues for a section, placenta previa. So then that time I met my chest physician friend. So she said, now you are better, well protected because 2 vaccinated dose झाले, COVID पण होऊन रिकवर झाला. त्यामुळे now you can do whatever you want. आता कोविड कमी होत आहे, पण आता गोदरेजचे खूपच कमी झालंय. ते नवीन दुसरं आलंय ते जरा घाण आहे, म्युकोरोमायकोसिस.
खूप आहे.
त्याचा एक व्हिडिओ बघितला मी, कुठं तरी आला होता. माय गॉड, सर्जरी खासली.
वी डोंट नो, आता सेकंड वेव्ह संपतोय, मे बी सम टाइम 2 months later 3 months later.
आज एक नवीन मेसेज आला विच इज वाईट, म्हणजे मी तो 2-3 ठिकाणी फॉरवर्ड केलाय. 2-deoxy काहीतरी आले ना एक ड्रग, त्यांनी 2-deoxy काहीतरी, DRDOचं. दॅट इज गोइंग टू बी
15 दिवसापासून चालू आहे, पण ते 15 दिवसापासून चाललंय, पण ते अजून काय इट्स दिसते ते आपल्या ते पेट स्कॅनला वापरतात ना, विथ क्लोरीन लेबल्ड. 2D CDU क्लोज इट इज पेट स्कॅन मध्ये वापरतात ते रेडिओ लेबल्ड असतं ते. आता प्रॉब्लेम काय तिकडे शॉर्टेज होऊन बसेल.
नाही पण इट विल रिड्यूस द रिक्वायरमेंट ऑफ रेमडेसिवीर, रिड्यूस द रिक्वायरमेंट ऑफ ऑक्सिजन वगैरे असं सगळं आलंय. म्हणजे देयर इज अ थिंग की हाऊ द वेस्टर्न वर्ल्ड इज ट्राइंग टू द फार्मा इज ट्राइंग टू मेक बिझनेस फ्रॉम इंडिया पॉप्युलेशन. हे सगळं हे वी आर ट्राइंग टू कव्हर इट. वॅक्सिन पण आपण घेतले आपले. बघू, लेट्स सी. There are some reports that this is the third world war, chemical war.
Whatever it is.
We have to write our MMC number and सगळं का?
You send your MMC number so that we can send you the
group
MMC point.
Group वरतीच पाठवू का?
Group वर पाठवू, chat वर पाठवू.
चालेल. प्रवीण राठोडच्या जी कोण आहे बोलणार?
We're just showing his recorded video.
Okay.
With the little silence for a minute or so.
Okay. There's a pre-recorded here session with lecture, with talk and everything.
Some other talk we are.
Okay, fine.
We have not removed it because I think we didn't feel like काढून टाकायचं.
आपल्या ग्रुप वरती पाठवू ना एमएमसी नंबर?
या चॅट बॉक्स मध्ये टाकला मी. आय पुट इन चॅट बॉक्स.
ग्रुप मध्ये टाकतो मी.
सचिन सर 2 मिनिटांनी चालू करूया का? ऑलरेडी 23 पार्टिसिपेंट्स आर देयर.
Yes, we will start on time.
Dr. Santosh?
Yes.
Should we start?
अरे 2 मिनिटं आहेत अजून.
Okay, चालेल.
4 o'clock ला एक्झॅक्टली स्टार्ट करू.
संतोष?
Yes.
हे प्रत्येक वेळेस पॉज शेअरिंग केलं तरी फक्त होतं का? स्टॉपच करावं लागतं? इफ आय वॉन्ट टू पिन इन बिटवीन स्टॉपच करावं लागतं ना?
हो.
Sachin, you can start.
Yeah, Santosh will start.
Just 1 second. Just one
Yeah.
second. Am I audible?
Yes, Santosh.
Okay. On behalf, good evening, everybody. On behalf of Navi Mumbai Obstetrics and Gynec Society, I welcome all the faculties and all the delegates who are joining with us today for this webinar. The theme of webinar is different strokes. So what we are going to do is we are going to discuss the topics related to different you can say subspecialties of obstetrics and gynecology to have an overview of the different topics, and we can get many take home points from today's webinar related to different areas of our obstetric practice. So first I welcome all the faculties and I hand over the program to Dr. Sachin Lokande, who is going to be our host for the evening. Over to you, Sachin.
Thank you, Santosh. Welcome to all again. It's very unfortunate to declare today that we lost two of our colleagues in last 15 days. First is Dr. Praveen Rathod, who is the first gynae surgeon of Bangalore, and second is very well-known, renowned person, Padma Shri Dr. K.K. Agrawal. He was a past president and very big name in the medical field. So it's our duty to pay condolence to them. We will be praying for you and your family until this time of suffering and sadness is over. May God give you the strength to overcome his loss. We just keep a mum for a minute. Om Shanti. Welcome to all to the webinar series, part 2, that is of different stroke by NMOGS. This is what is our schedule today. Few announcements. Please put all your questions in the chat box. Those will be answered at the end of each talk. This webinar is also streaming live on NMOGS YouTube channel. Our first speaker, Dr. Samir Pradhan, he's MD, DNB, FRCS, DGO, and DFP. Sir is a Joint Secretary, Maharashtra SOVCI, Life Member of FOXY, NMOGS, IAG, and whatnot. Associate Life Member of TOGS and AFG. He's a Director of Samarth Maternity and Nursing Home, Mulund. He's also attached consultant at Godrej Hospital, Shushruth Hospital, and Hiramongi Navneet Hospital, Mulund. He's a visiting consultant at Jupiter Hospital and Curie Hospital, Thane also. His special interest is gynae endoscopy, vaginal surgeries, and high-risk pregnancy. And he's invited, everybody must be knowing, we are seeing him as a moderator in all live workshop process. Sir, this is the topic. You know all the types of hysterectomies, robotic, laparoscopic, and abdominal. But today, he's going to speak on a very different topic, that is no hole surgery, that is non-descent vaginal hysterectomy. It's to you, sir.
Thank you, Dr. Sachin.
Yeah.
At the outset, let me congratulate NMOGS team for such a nice webinar. I'll just share my screen. Is it seen well?
Yes.
And am I heard well?
Very well.
Yeah. One sec. So, just give me 2 minutes. Can you hear me? Hello?
Yes, sir, we can hear.
Dr. We can hear you.
Yes.
Yeah. No, what happened is I had kept the gallery view, so I could not see my slides. Sorry for that. Yeah. So tips and tricks of non-descent vaginal hysterectomy is the topic. Now, non-descent hysterectomy is actually a misnomer because physiologically, every uterus has a mild descent and a vertical mobility. So what we mean by a NDVH is a vaginal hysterectomy done for non-prolapse indications like leiomyomas, adenomyosis, polyps, abnormal uterine bleeding, or cervical dysplasia. And in lighter vein, some people call it normally difficult vaginal hysterectomy. As a primary aim of all surgeons or gynecologists is that we should do no harm, as said by Hippocrates. That is primum non no sear. So there are certain absolute contraindications, like you can see in these photos. If there's a ventrofix uterus because of a previous laparotomy or a previous cesarean section, or there is deep infiltrating endometriosis which you have diagnosed, then I personally feel that one should not attempt a vaginal hysterectomy. The other absolute contraindications being a previous psychovaginal fistula repair, or obviously malignancies. Shoutas is now we have not seen also, and I don't think it is anymore a part of modern gynecology. There are certain technical problems to do a vaginal surgery, like a narrow subpubic arch which is less than 90 degrees, or the vaginal accessibility is hampered when there's an intertuberous diameter is less than 9 centimeters. Arthritis of hip joint can cause sometimes a difficulty in abduction, and then you will not get any space to operate. So in a pre-op evaluation, one should always do a transvaginal pelvic sonography, wherein one comes to know the size of the uterus, and the volume of the uterus is more important than the size, wherein the transverse diameter of uterus is important. A sonography also helps us to differentiate between the leiomyoma and adenomyosis. Obviously, one can come to know adnexal masses and rule out ovarian malignancies. As a habit, now I started doing an abdominal and a pelvis sonography, mainly to diagnose any hydronephrosis or hydroureter. This is more so in the case of prolapsed uterus or a broad ligament fibroid. So the one has to be aware of the ureter problems. One should always check for post-void residual urine, so it can help to diagnose and prevent a case of retention. With high uterus in the case of previous LSCS, and one of my friends who is doing advanced surgery does the sonography after bowel preparation. So he comes to know about the rectal involvement in deep infiltrating endometriosis. The most important test is PS, that is examination under anesthesia preferably. The important first test is a traction test, which we all have been doing since our first post. And the uterus descent is noted. The external loss should, in relation to the level of ischial spine, has to be noted. I always check the uterocervical length with a sound, either to rule out a supravaginal or an infravaginal elongation. The infravaginal elongation of cervix helps to plan the initial incision on the cervix. Now for the ventrofix uterus, which I showed in the first few slides, there is something called, Dr. Shirish has described as a shade cervicofundal sign. It indicates a ventrofix uterus. In a ventrofix uterus, the posterior vaginal wall is stretched and pulled upwards in the upper half. And when one puts a speculum, one is not able to visualize the cervix, because the cervix is placed almost behind the pubic symphysis. By difficulty, once if you can hold the cervix and give a traction, it will cause dimpling of the anti-abdominal wall. For a deep infiltrating endometriosis, one has to hold the posterior fornix, and then once is puckering in the fornix, and on lifting the posterior fornix, there can be retraction of the posterior vaginal wall. So besides giving the volume and size of the uterus, EUA also helps us to know the mobility of the uterus and ascertain the adequacy of uterus-free space in the pelvis. The transverse vaginal enlargement is more important, and if one can rule out this angle, that the uterocervical angle between the fundus and the cervix, the more obtuse the angle, the more easier the hysterectomy. And the right angle and acute angle, then the hysterectomy vaginally is a bit difficult, and one has to take a laparoscopy help or do a open hysterectomy. So this is a correlation between the size of uterus and how a gynecologist should climb up the learning curve. I think up to 300 cubic centimeters, everybody should be able to do it easily. With up to 300 to 400, sorry, 300 to 350, one needs debulking. And above 400, that is corresponding to more than 18 weeks, it has to be a trial of vaginal hysterectomy. One requires special instruments. A Landon's retractor is very important. One can have angulated Landons for better exposure. A Breskin Aurathil retractor, which is not taught to us, but it is a very useful instrument, and if one can get it, it is a useful tool. I have something called a Purandaras retractor, which I'll be telling later on. Single-bladed SIMS is important because it can be moved on the sides of the thigh and helps to use a do lateral retraction. And a Sonawala speculum or a Award speculum can help to make one assistant's one hand free. Position is lithotomy always. Flexion at the hip and knee joint. buttocks projecting slightly beyond the edge. One has to avoid the Lloyd Davis position of laparoscopic surgeries, because then the space is less for operate. Special stirrups are there to protect the pressure points and prevent nerve compression. This is a view of the modified Dr. Paili's stirrup. And hyperflexion of the hip can cause stretching of the sciatic nerve. So I normally just do normal flexion, but there are certain surgeons who prefer hyperflexion. Prolonged groin folding causes compression of lateral cutaneous nerve of thigh and cause numbness and tingling of the anterolateral aspect. And the lateral peroneal nerve can get compressed in the neck of fibula. So we have to mark a pad, put a pad or cloth at that pressure point. The first step is always exposure. Labial sutures are something which I use for exposure. I have never used a gel self-retaining retractor because I feel it occupies more space. And one can take a cervical traction sutures or use a bulldog valsalem to give a traction on the cervix. Infiltration is optional. I always infiltrate if allowed with saline, with adrenaline or with vasopressin dilute. Or if it is not allowed, then I use cold saline. One has to move the uterus up and down and see where the crease is, and the first instance at the cervico-vaginal junction, and one start dissection in the vesico-uterine space. This is one important point which I want to tell. I call it, it was taught to me by my mentor, Dr. Amar Bhide sir from Wadia. Now he's in UK. He used to make me identify this ridge. The ridge is nothing but the junction of the cervix and the uterus. I use this landmark also for my Shirodkar circlage. So while dissecting, if one goes below this ridge, one tends to go and dig in the cervix and lose the plane. So once this ridge is found, one has to do sharp dissection just above the ridge, not very boldly. The Landon should retract the bladder, and then one can reach the A pouch. Now let us see the surgeries. This is after the incision is taken, and we are doing sharp dissection in the vesico-uterine space. The initial dissection has to be sharp so that the fibers start retracting, and then one can use a blunt dissection. One may open the A pouch immediately or later. And in a case where the hysterectomy is done for non-descent indications, the P pouch should be opened layer by layer, identify, and then only opens. Initial days I had opened a rectum extraperitoneally. Now here the A pouch is being opened, and then one can put the Landons in the A pouch. Then we take the right uterosacral pedicles. One clamps it. I always apply a hemostat as a safety, and it can be loosened while tightening. And the fixation is Heinisch type of transfixation. Always the first knot is a surgeon's knot, double throw and squared, and then subsequently 3 more knots. And I also go around it because in Heinisch state, sometimes one tends to miss the medial fibers. And if it's a bulky uterus, there can be a dilated vessel from the branch of descending cervical. So it can cause bleeding and spoil the field. So this technique is very useful for that. And the uterosacral stumps always pedicles are kept long. This is the left uterosacral. Note how we have to maneuver the needle. The needle is held in a special slightly angulated position, and one has to go vertically from up down. Avoid the locking of the sutures. Tie with the fingers, make a square knot, first double throw, place the knots with your finger, otherwise the knot suture might break. Then release the artery, and then take the subsequent clamps. The uterine pedicle has been taken over here. One can use a scissors, knife, or a cautery. If one uses cautery, we have been taught nowadays by COVID that the fumes have to be sucked immediately. So assistant has to hold a suction. The needle has to go vertically down. Here you do not transfix again. You can only transfix once. And the knot is placed. For all vascular pedicles, I always prefer to take a free tie. I'll show subsequently. Here we're taking the left uterine pedicle. Now left side you can go from below up. So there's a different way. So the stump will face you. When you tighten this stump, just see how the maneuvering happens, and the pedicle can face you, and you get enough space so that you can have a broad pedicle and there is less chance of the pedicle retracting. So this is a good technique which was taught by my sir. And here I'm taking a free tie. I take a 2-0 Vicryl on a hemostat, go around, and again transfix. This is also mentioned in Taillands and always stressed in all the conferences by Dr. Shirish Shet sir. One suture for the safety of the patient and one for your good night's sleep. For all non-descent cases, always make a habit to take this ascending uterine branch after the uterine. And the same way it is been tackled on both the sides. And whatever one has to do debulking procedure should be done after this step, because it helps to aid the dissection further. And here we are showing lash subserosal coring. It is preferred technique for a transverse elongated uterus, especially adenomyosis. One has to be inside the in the serosa and avoid lash at the cornu. I had once transected the cornu and the thing had retracted, and it was very difficult to retrieve it. Always 2 clamps or the pedicle and a hemostat. Hello. Yeah, and after this pedicle is taken. Can I continue? Hello. Yeah, so this is a transfixation. Here we have to transfix in a different manner. One goes from the center of the pedicle and goes around. And the lower part is tied first, and then one can go around and tie the other part. This is the left cornal pedicle being taken. Similarly, we are going and transfixing the pedicle. Nowadays, we do opportunist salpingectomy for all the cases. This is showing the right salpingectomy being done. The Babcock is holding the fallopian tube, and we have applied the clamp, and we have removed the tube. And one can just take a ligature twice so as to achieve hemostasis. This is the left salpingectomy being done. So this is a part which we have started incorporating for all our cases. We'll see why it is done. So the take-home points are: the posterior pouch has to be opened layer by layer, unlike in a case of prolapse uterus, where the P pouch is quite low down and one can directly open the one bolt cut. The anterior pouch can be tackled immediately, or sometimes if it is not accessible, one can tackle it after taking the uterosacral pedicle, which aids the descent. I always use a Mengots clamp or a Atrogrip clamp. Hines type transfixation is done with number 1 Vicryl, code number is 2347. Free tie for vascular pedicles is with 20 Vicryl, 2317. Lash subseroral coring only after the ascending branch of uterine is taken. Avoid coring near the cornu, as it can cause transaction and retraction of the gonadal vessels. If you notice in the video, the left index finger guards the bowel during the right cornual clamp. The valsalum can give traction to one side of fundus for the opposite cornu if there is a space constraint. We can see in the next video. And the opportunistic salpingectomy is done to prevent a post-op pain due to a hydrosalpinx, especially in case where a TL has been done earlier. And it also reduces the incidence of epithelial cancers of ovary in future. So one has to use a Babcock gently on the fallopian tube, pull it medially, and use a Shades clamp or a Pailis clamp, which we'll see later on. I always close the visceral peritoneum with the high ligation of the posterior pouch whenever feasible. It definitely prevents an enterosil in future. And when we have opened the posterior pouch layer by layer, there is a space between the posterior peritoneum and the posterior vaginal wall. And one has to suture it or achieve hemostasis in this by figure of 8 or a continuous suture. So this is the place where hematoma occurs and it can get infected subsequently. One always should anchor the uterosacral pedicles to vault at the angle, this is the De Lancis level 1 support for the vault. This is another video where we are going to see some other bisection, the bisection technique. Here there was a transverse diameter enlargement, so we could not reach above. So we bisected the part after taking the descending cervical clamp. So the descent increased, and then we took the uterine pedicles. This is the ascending branch of uterine being taken. And the final bisection was done after this ascending branch was taken. So one can be opportunistic, take whatever is seen, bisect up to that much level, and then go step by step. So here we have now we are completing the bisection up to almost the fundus. So the uterus starts descending when you bisect, and then again my left finger is guarding the bowel, and the right right cornal pedicle has been taken. Here after this pedicle, we can either take both the side pedicles if there is space, but if there is no space, one can push the specimen inside. Take that pedicle and then again remove the specimen with a clamp. So here also see the left index finger is guiding the bowel when one is in cautery, and one can go from the center and go and bisect on the other side. Now what to do to prevent the slippage of clamp? Proper stout clamps with vertical lines on inner side of clamp, that is called Mengots clamp. They have to be used. pass the suture at the tip of the clamp and transfix and then cut the pedicle. This is one alternative step that some people transfix the pedicle first and then cut it. That is individual habit. Don't cut and only ligate the pedicle. One can apply extra hemostat medial to the clamp, which I do if there is a space. Carve the pedicles from the specimen. Keep the uterosacral pedicles long. So if upper pedicles slip, one can always catch hold of it, retract it medially, and identify the bleeder. A free tie is preferable to all the vascular pedicles to ensure prevention of post-op hematoma or reactionary hemorrhage. If there is a slippage, don't panic. One has to visualize properly. So suction cannula with a Yankush tip suction is important. Retract the lateral wall. Use a Landon's retractor. Push the uterus on the opposite side or inside if possible, or remove it and then tackle the pedicle. Avoid clamping blindly. Hold the bleeder. Identify it with a hemostat or Alice forceps. Replace it with a mixture if one is very close to any major bowel structure or bladder or any major viscera. And religate or take a figure of 8 suture or use a bipolar forceps or a biclamp. Now, in this case, we'll be seeing debulking during hysterectomy with a myomectomy. So both the uterine pedicles are secured as per our rule, and then one can give a traction with a bulldog valsallam on the myoma. One can incise the pseudocapsule of myoma and give a gentle traction. Mind you, the traction has to be very gentle. If one just pulls very fast, it can just transact the whole uterus or the pedicle from the lateral side. And the bulk will increase. Now, this is a technique called Prior's technique where vertical wedges are removed from the center. So it is called coring, but in adenomyosis, the tissues are non-yielding. Everybody knows. The hemosiderin in the adenomyotic tissue makes it very unyielding. So whatever is seen, we have taken the lateral pedicle, whatever we can see, and we have, this is a Paniker's knife, it has an angle, and the blade, one can keep on changing the blade as it becomes less and less sharp. And we are holding wedges and removing proper wedges from the center. The aim is to remove whatever tissue which we can see in the center, and then as we access the lateral pedicles, one can remove those pedicles. So this patient was actually posted for laparoscopic hysterectomy last year in April. Because of COVID time, I had to shift to do a NDVH. I had told her a consent for a laparotomy also, SOS. But in initial days, I think laparoscopy was not allowed. So we went step by step. We removed a fibroid which came in the way. We had to keep on assessing our space with the finger. Don't pull too much. Give gentle traction. A calcified fibroid is difficult to manage, but ultimately in this patient, we were successful. So patience and perseverance is the key. So this is the first specimen is of the same patient. We first did something called bisection of only the cervix. Then we did transaction. Then we removed those wedges, which we say this called described in the textbook as a Prior's technique. We removed few myomas, and ultimately we could remove the whole specimen and also remove both the tubes. Sometimes you have to use a combination of transaction first, with there's an infravaginal elongation, then bisect. And the purpose is to create a lateral uterus-free space so that your pedicle is seen properly. Sometimes there is a hydrosalpinx, as in the second photo picture, and that has to be removed. Occasionally there can be a cornual fibroid, but then what one has to do is remove one side completely, and then automatically the uterus can be made horizontal, and the other clamp side, the pedicles can be exposed because we get more lateral space on the other side. Now, in this particular, it's another fibroid in a case of previous LACS. We were not able to open the A pouch, so we just gave a traction on the fibroid, and luckily the A pouch also got opened. But it is not a very recommended thing because sometimes it can cause a bladder injury. So salient points for fibroid removal, it has to be done after the uterine or the ascending uterine pedicle is taken. Instruments like bulldog valsallam, tenaculum, or if you don't have anything, then towel clips also useful, the Beckhouse type of towel clips. Myoma screws of different dimensions are essential. Bisection is better if there is an adenomyosis or a supravaginal elongation, but transaction is useful if there is a infravaginal elongation of cervix or a broad ligament myoma. Lash technique or subserosal coring or Prior's technique are useful to in adenomyosis. And sometimes there's a cervical myomas, one can infiltrate dilute vasopressin in the myoma bed and enucleate like one does in laparoscopy, and then attempt the further hysterectomy. So these are the special instruments which are shown. If there is a enlargement at the fundus, then the angle between the cervix and the fundus is obtuse. And then if the size is even 18 to 20, one can still attempt to do the surgery vaginally. And in broad ligament fibroids, I feel that one should transact and then go for the broad ligament, enucleate the fibroids, and then complete the hysterectomy, as shown in the last photo. Now coming for bilateral salpingo-oophorectomy during hysterectomy, instruments required are a Shades clamp and a Landon Purandaris retractor. So one holds the ovary with a Babcock and gives a traction medially and applies the Shades clamp. And I also apply a hemostat medially to it for safety, and the tube and ovary are removed. One transfixes it, and while transfixing, one can take the lower stitch first and then go around because it is more near to you. This is taught to us by Dr. Paili, sir. Transfix lower end first because it is easier to access. If the bowel is coming, one can put a roller pack and retract the bowel. And here we are seeing the left tube and ovary. It is slightly more difficult because the sigmoid comes there. One may have to reapply and the clamp till one reaches the infundibulopelvic ligament. Nowadays, we have a new technique, V-notes, that also is very useful for such things. But it is possible vaginally also. So the important points for a vaginal salpingo-oophorectomy or adnexa removal, I just shown I used this strings of the mask to just demonstrate. These are the suppose this is a pedicle. One has to put a roller pack to push the bowel, Trendelenburg position to take the small bowel away. A broad Purandaris retractor replaces a narrow Landon's retractor. Round ligament has to be taken separately after the ascending branch or with the ascending branch as laterally as possible. Only then the ovaries come down. Babcock forceps gives slight traction to the ovary medially. Use the Shades clamp in this way or a Paili's reverse clamp. I found Dr. Paili's clamp a bit difficult because I have never seen it been used. I just saw in a conference and just bought it. Use a free tie or one can, if you has a Arbe biclamp or a ligashow, one can use that. Or initial cases, you always keep a laparoscope ready. So if the pedicle slips, then one can always put a laparoscope and cauterize that last pedicle. So here I got a good photo how a clamp can be applied. The Babcock is pulling the ovary. This is the right side and the left side, both are seen. And the Shades clamp has gone on the infundibulopelvic ligament, and the Paili's clamp is a reverse clamp. So we can remove a large ovarian cyst vaginally, or if the bulky uterus also we can remove both the tubes and ovaries. And the last photo is about a very postmenopausal woman. I attempted it because she had some other history of CA breast. So I had to remove the ovaries, and it were possible vaginally. Otherwise, I told her that after the hysterectomy, I will do a laparoscopic bilateral salpingo-oophorectomy. So in the postmenopausal age, it is more difficult. Now coming to previous LACS, Dr. Shirish has described a space called a lateral space. There is a lateral 1/5 where there are no adhesions. So this is very important space. And the tips and tricks are, if the pouches are inaccessible, one can do the whole hysterectomy extraperitoneally, safeguard the bladder and rectum. There is a technique called Pelosi technique where the posterior pouch is opened by cutting the posterior lip vertically from the external os cranially. Dr. Shirish's space, which is also seen in laparoscopy, we can be identified. It is just anterior to the uterine vessels. Anterior lower myomas can be enucleated before attempting the A pouch removal. In a normal volume uterus, after opening the P pouch, one can pass a finger from behind and over the fundus or laterally and reach the proper plane. Dr. Purohit sir is doing a lot of such cases, and he has a posterior anterior approach. He has a special large mixture where he dissects the fascia and isolates the vessels and then cauterize each and every vessel and helps to get in the right plane. And for those who want to increase the curve of vaginal hysterectomy, one should attend Dr. Suraj Naval's V-Notes course. Here in a previous LACS, after opening the P pouch, one shifts to laparoscopy with his modifications. And the pneumoperitoneum which goes, when it is seen through the peritoneum, it is called a gray sign because we get a grayish hue. And the peritoneum flutters, so it's called a wave sign. It can help to go in the right plane. But there can be surprises. This is the right side photo is about a previous 3 LACS with adenomyosis, which I had attempted vaginally, and I was successful with the aid of bisection. And the next case was a similar case of previous 1 LACS, and the cervix was lying outside the introitus. I got overconfident and I felt that this can be a single LSS. I have done 3 LSCS, so this will be simple. But it was an infravaginal elongation of cervix. The fundus was stuck, and there was I could not open the A pouch by all the techniques which I have described earlier. Then I put a laparoscope, and it was a ventrophyx uterus. So I had skipped the initial steps of examination. So one should never be overconfident for any surgery. That is the key from this lesson which I have learned. And the conclusions from my talk are skill augmentation of vaginal surgery can avoid need of expensive endoscopic surgeries, especially in the COVID era where the anesthetists sometimes prefer not to give GA. Vaginal salpingo-oophorectomy bilaterally can be learned by a methodical approach. Vaginal hysterectomy can be performed in cases of previous LACS, but it should not be the first case. One has to climb slowly on the learning curve. And as one grows in confidence and skills, the contraindications which I mentioned in our PG days for vaginal approach reduces. And V notes, that is the vaginal natural orifice transluminal endoscopic surgery, can be added to one's armamentarium to widen the scope of scarless gynec surgeries. I would like to acknowledge Dr. Sarogi sir for all his teachings to the live workshops. Late Dr. D.K. Tank had given a nice oration just after I had passed MD way back in 1997 at NMOGS, wherein he had described all these techniques in detail. And though I was Dr. Shirish Sheth's intern, I never had to work, not a chance to work with sir. But sir is always a part of live demonstration workshops, and he keeps on encouraging juniors and youngsters. And I have learned from a lot of his AFG workshops and Foxy workshops. I bought this Dr. Shirish Sheth's vaginal hysterectomy textbook, and it has described each and every step in detail. And once sir came to know that I do advanced work, he presented me with his second edition of this book. Not edition, advanced vaginal surgery, another textbook, with a nice comment. It is with pleasure sending this book. It contains contraindicated stuff. As experience increases, contraindications decrease. Hope it promotes vaginal surgeries. And with this last slide, I request all of you who are interested in vaginal surgery to become a member, life member of an organization started by Shirish Sheth sir, Dr. P.C. Mahapatra, Dr. Hara Patnaik, and Dr. Sarogi sir. It is called SOVSI, Society of Vaginal Surgeons of India, and the entry fee is only 2,500. Anybody interested, I can send a form across. Thank you very much for a patient hearing.
Thank you, Dr. Samir. Thank you. Any questions for Dr. Samir? Any questions for Dr. Samir here?
There are no questions in the chat box, Sachin.
Okay, so I think just one question I just want to ask Dr. Samir. Dr. Samir, yes. You are using the bipolar, knife for cutting all the pedicles. So
not bipolar, unipolar.
Yeah, unipolar. Yeah, unipolar cautery. So do you think it is always safe or?
No. One has to be. You cannot have the whole. Only the tip has to be exposed. You have to be covered. Otherwise, you can cause a vulval burns also sometimes. And the advantage of doing it after doing laparoscopy surgery is, we know, like if you anybody attended Dr. Rakesh Sinha's initial just hysterectomy conference and all, the medial bleeding which happens, one can always use a cautery, and if it's on the spray mode, the small vessels, it just gives a more cleaner field. It is not compulsory. One can use like after this COVID era, I have again shifted to knife. But when you have a cautery with a nice advanced bipolar or whatever, it is always aids. I have done few cases only with bipolar also, but the learning curve was always with suture. So though for laparoscopy we use only cauterization, in vaginal I have not shifted to complete use of only cauterization. I still, even if I cautery, I take a stitch. So it's a mindset.
Thank you, Dr. Samir. Moving to the next talk. Our next speaker of honor is Dr. Nagendra Sardeshpande. Sir is a consultant endoscopic surgeon at Bombay Hospital, Sir H.N. Reliance Hospital, Breach Candy Hospital, Saifi Hospital, Okad Hospital, LH Hiranandani Hospitals, and obviously the prestigious institutes in Dubai and Sharjah also. He is a past managing committee member of NMOGS and IIG. He has got publications and presentations in national and international journals. That is laparoscopic correction of chronic uterine version in JMIG 2009, His special interests are in endometriosis and laparoscopic radical surgeries. Today, the topic given to sir is, you can see here, the intrauterine pathologies that affect the fertility. It's to you, sir.
Thank you
Dr.
very much
Nagan.
for this. Yeah, can you hear me?
Yes, sir. Yes, sir.
Thank you for the kind words.
Yes,
And yes, here we come from vaginal surgery to one more surgery, which is again underutilized in our day-to-day practice. Like I always say that if you're a urologist, you can't say you don't know cystoscopy. Similarly, if you're a gynecologist, you can't say you don't know hysteroscopy or vaginal surgery. It's criminal. And but at the end of the day, every technique, every method, every technology that we use in our practice has to be, you have to sit down and analyze that, have you done justice? Just because the technology is available does not mean you have to keep on implementing it left, right, and center. So let's have a look at why we do evaluation of the uterine cavity by whatever method, whether by radiological investigations or hysteroscopy. Our primary aim is to diagnose a pathology which can impair fertility. Second is we have to determine what kind of therapy she needs. Sometimes you have a big fibroid, it is too big for a hysteroscopic approach, although it is submucous, so you may have to do a laparoscopy. And then, of course, after that, you diagnose and or treat the pathology, you have to decide the further fertility treatment. There is a secondary aspect to this, that is you have to follow. You sometimes have to use this evaluation method, means of evaluation as a follow-up of the surgery. Sometimes during fertility treatment, you can have some new pathology arise which needs intervention and which may need a change in the mode of therapy. And of course, the older pathologies, say small fibroids, which are initially intramural, can start projecting to the uterine cavity. So you have to treat that pathology during the course of your fertility treatment. So essentially what has happened is in the last 2 decades, there has been a radical improvement in our radiological investigations. And we all know that some of these investigations, that is your 3D ultrasound, hysterosalpingogram, the gel-based radiological, the ultrasound, that is the HICO-C, are almost comparable in sensitivity, specificity, your positive, and negative predictive value, and correlation with endoscopy, and they're almost comparable to that of your endoscopic evaluation of the uterine cavity. So, and when you have different classes of investigations, when you for evaluation of the pelvis, you can see that the sonohysterogram, 3D ultrasound, and MRI are as good as the hysterolaparoscopy. And in fact, 2D ultrasound and the hysterosalpingogram come a little lower down the pecking order. But if you combine these two together, wherever 3D ultrasound is not available, then they come as close to endoscopic evaluation as possible. So hysteroscopy can be used in infertility either alone or in combination with a laparoscopy. So when you have a patient with unexplained infertility and you perform a laparoscopy and a hysteroscopy, you can find pathology from 20 to 60% of cases. However, there is a change in treatment in less than 5% of cases. So really, it does not have such a major impact on infertility treatment. Also, the second part is that when you compare endoscopy performed and then followed by IUI, or an IUI directly performed alone directly, when there is a normal radiological investigations, the pregnancy rates are not significantly different. Hence, in the absence of a radiological findings of pelvic pathology, a routine histolaparoscopy is not encouraged. Whereas when you go to the next part of that, that is, suppose you have a patient, we have tried 3-4 attempts of ovulation induction, maybe IUI, and if she's not conceived, then the chances of finding pathology is almost 60%, and hence there is a 20 to 25% chance that you'll change your treatment plan. It also helps in 2 aspects. One is you'll detect the pathology and you treat it, and you can change the course of treatment. And second is, this is the time, 3-4 cycles of treatment, when the patient is likely to drop out, and hence you can treat the pathology and then keep her interested in continuing her treatment cycle. And in case of IVF, although pathologies are detected in 30 to 50% of cases with a combined hysterolaparoscopy, there is no improvement in the pregnancy rates by and large. When you look at just the diagnostic hysteroscopy alone, almost 20 to 25% of patients, you'll find some form of pathology in the uterine cavity. And majority of them seem to be endometrial polyps. And of course, we'll come to that later, the results of polypectomy. And the other things that you can find are adhesions in a small number of cases, and uterine abnormalities in about 10 to 15% of cases. The commonest ones, of course, as we all know, is the septum and the arcuate uterus, and rarely other kinds of intrauterine abnormalities. So the question was, does a routine hysteroscopy, is it important before an IVF procedure, since it's such a high cost procedure that we are talking about? And for this, there have been two important trials in the first half of the last decade. One was the INSIGHT trial, which compared groups who received a hysteroscopy before IVF cycle or primary IVF cycle, and the other was who underwent a direct IVF cycle, who are undergoing primary IVF cycle. And they found, and this is, of course, these are patients who had normal radiological findings, and they found absolutely no difference in pregnancy rates. So hence a routine hysteroscopy before IVF, assuming a normal transvaginal ultrasound, is really not justified. And the second was in patients who had recurrent IVF failure. That was a trophy trial. And there again, doing a hysteroscopy, if you have a normal radiological finding, did not seem to have any additional benefit, in fact, and wasn't really cost effective. So really, as I said, radiology has come a long way today, especially a 3D ultrasound, and hence routine endoscopic evaluation of the uterine cavity is not really warranted. And what about a relook hysteroscopy? Because some of the procedures that we do on hysteroscopy, that is a myomectomy, especially when you have multiple fibroids on opposite sides of the uterine cavity, and when you do multiple polyps, and when you are doing adhesional, the chances of recurrence are as high as 20 to 26%. And hence, in such cases, a relook hysteroscopy is possibly justified. However, the question arises that there are no studies. I went to the literature, but there are no studies of comparing a relook hysteroscopy with a 3D ultrasound post procedure. So we really have no idea about that. When to do the relook hysteroscopy? About 1 to 2 weeks following the primary procedure seems to be the ideal time, because when you do the hysteroscopy at the time, do a lysis of what the adhesions have formed, the chances of re-adhesion formation are very, very lower as compared to if you do it 1 or 2 months later. This is probably because the earlier adhesions are pretty flimsy, and then they have not had a chance of becoming more fibrotic or fibromuscular. Of course, in our scenario where we have a large incidence of tuberculosis in some parts of India, a second look hysteroscopy will be quite important when we are treating patients with genital tuberculosis as a follow-up to a medical treatment, to see if there is any chance of getting a normal or reasonably normal uterine cavity to that woman. So the next half of my lecture is, when would you consider, now you had a pathology, so when would you consider an operative hysteroscopy in patients who are undergoing treatment for infertility? So for that, the question that you would ask is, suppose you find a pathology on your hysteroscopic examination in that woman. So example, you have a small dent in the bump in the fundus of the uterus. Is it really associated with infertility? And is it going to, if you treat that pathology, is it going to provide any sort of benefit to the woman? So if you compare the various pathologies that we're treating, this was actually part of my broader lecture on endoscopy in infertility. So now I've compressed it to just focus on hysteroscopic aspect. So these are the pathologies that we can encounter on hysteroscopy. One is, of course, when you have a HAG showing a tubal block, and 60%, we all know that if you're not doing the HSG very well, if you're not doing it yourself, if you're not doing it properly, 60% of HSG blocks are actually patent tubes, and 3% conceive spontaneously. So there is a role of endoscopic evaluation and possibly tubal cannulation. And uterine fibroids, a lot of controversy. More than 2 centimeters, less than 2 centimeters, so many theories about whether they actually cause infertility, and possibly they may be a contributing factor for spontaneous abortions. Intrauterine synechiae, as we all know, do contribute to infertility, and there may be associated tubal factor with that. Plus, of course, when the patient conceives, when you have a large number of intrauterine adhesions, you have a higher risk of spontaneous abortions, preterm delivery, and an adherent placenta. In case of Mullerian anomalies, there are two parts to that. The one is you have got a canalization defect, and the second part is when you have got a unification defect. Canalization is your septum and your arcuate uterus. They have been associated with reduced implantations, and of course, but this does not seem to be the case with the unification defect, that is your didelphic or the biconate uterus. But both these can lead to spontaneous abortions, preterm deliveries, malpresentations. Cervical incompetence, we don't know. It's pretty controversial. Endometrial polyps have been shown to be associated with reduced implantation. We'll come to that 2 centimeter and 2 centimeter a little later. Foreign bodies, of course, they can act like a contraceptive, like a copper T, and they can reduce implantation. Whether they will have an effect on pregnancy outcome once she conceives is controversial. It's almost seen the new kid on the block. Seen a lot of studies coming out in the last second half of the last decade, possibly altering the cervical mucus with impaired sperm transport. However, they do not seem to affect the results of IUI and your frozen embryo transfer. And of course, when you have a isthmosil, you have a risk of a scar rupture in pregnancy or a scar ectopic pregnancy. So overall, if you look at it, there was a nice, the study which meta-analysis of the all the trials that have been done so far by Bostiels et al. And the unfortunate part is that there have been so many studies on so many pathologies of for hysteroscopy, but there have been very few or virtually no randomized controlled trials regarding this. They are small studies, and which with just hints and guesses, they will suggest that yes, this pathology may interfere with implantation, may interfere with pregnancy, may interfere with outcome, but there is no clear evidence of on any of this pathology, which is very unfortunate, since considering the large number of IVF cycles which are being done all over the world. So let's look at each pathology by individually. So when you consider hysteroscopy for hydrosalpinx, that was the issue came as a it was came as the magic pill. It was supposed to totally obviate the need for an endoscopic delinking of the fallopian tubes. And yes, compared to doing nothing for that, this hydrosalpinx, the pregnancy rates and the live birth rates are much higher, but they are inferior when it comes to a laparoscopic delinking, possibly because the ends of the issue will project into the uterine cavity, may themselves act as a contraceptive, as a foreign body. So yes, wherever possible, do a laparoscopic delinking, but it's really difficult, which is really the rarest of rare scenarios. Then you can consider a Yeshua device. What about tubal block? And in case of patients with reasonably normal tubes, in which there was a meta-analysis of 27 studies of unilateral or bilateral tubal block were cannulated, and a pooled cumulative rate at about 9 to 12 months reached about 25 to 26%. Beyond that, there were pregnancies, and at 48 months, you had about 28% patients becoming pregnant. But between 12 and 48 months, there did not seem to be a great increase in the benefits. So up to 9 to 12 months, if you have a successful cannulation, you can have a reasonably good chance of a pregnancy, spontaneous or with IUI. And the ectopic pregnancy rate is pretty acceptable, 4%. So there is a scope for tubal cannulation of these tubes, if they are healthy tubes. And I personally prefer to use that the ureteric catheter, the 5 French ureteric catheter for the cannulation, since it is softer and much gentler on the fallopian tube. When it comes to hysteroscopic adhesiolysis, most studies seem to show benefit in case of mild to moderate disease. We have 3 grades of this disease, and the most severe grade is almost the entire cavity is obliterated, or the adhesions are densely fibrotic or fibromuscular. These are the diseases where the improvement there doesn't seem to be an improvement in the term pregnancy rate or the pregnancy rate itself. There is a new study which show that actually if you excise these adhesions and expose the underlying myometrium, then the pregnancy rates seem to be much higher as compared to just division of these adhesions with scissor. We need more numbers and more or some sort of RCT to really to justify to validate these findings. And of course, you have to see there are other factors often associated with this with intrauterine adhesions, like advanced age. If you have now how many procedures to be done, normally we limit to 2 or 3 surgeries. What I rule of thumb I follow is that I've done when I do the primary procedure, the hysteroscopic adhesiolysis, I just check out if I have some endometrium to handle. If there is some endometrium in the cavity, then it can likely regrow over the cut area. At the second look hysteroscopy, I check out is there an improvement over the previous picture. Then I go ahead and try and complete the procedure. So maybe 2 or 3 attempts at creating a cavity. Otherwise, I think it's not worth it. Surrogacy will be a better option. Severe adhesions, again, we are less likely to have a good outcome. Cervical canal adhesions, studies have shown that they have a poorer outcome. But I personally feel when you put a Foley's catheter in the uterine cavity, manage to keep the cervical canal open, then you can have a better outcome. Which works better? Studies show that scissors work better than electrosurgery. And I personally agree with that, because you're already dealing with a cavity which has poor vascularity. So compromising it further does not seem to make any sense. And scissor is an easy and a quick approach for this technique or for this pathology. In case of hysteroscopic myomectomy, as I said, there have been no randomized controlled trials about whether hysteroscopic myomectomy helps in when you treat submucous fibroid. But most of us agree that small studies and in our experience, removal of a submucous fibroid can bring about unexpected spontaneous pregnancies, and especially when the patient is going to go for IUI or more advanced procedures, removing the fibroids makes sense. Whether to use bipolar or monopolar or your the newer one, your hysteroscopic oscillator, really your guess is as good as mine. I personally am still a great fan of the monopolar. I still believe that it works much better. It is much faster and it is much smoother. I have used the technique which was proposed by Dr. Nozer Shariar, and I still use gravity to resect out these fibroids. It works very well with very little absorption of fluid. And there's an interesting study which showed that the larger and the deeper the fibroid that went into the uterine, in the uterine diameter, that is a 0, 1, and 2, the lesser the chances of success of your procedure. That the pregnancy rate, there were pregnancies, but the pregnancy rate gradually declined as you dealt with the deeper types of fibroid. This is possibly because of disruption of the endometrium, the junctional zone, and the vascularity, the vascular supply to the overlying endometrium. In case of endometrial polyps, there are a lot of studies. The incidence is extremely variable because all of us know that many times ultrasound reports the uterus as normal and we find the polyp on hysteroscopy and vice versa. What is interesting is that polyps at the uterotubal junction and multiple polyps seem to have a greater impact on fertility, and pregnancy rate seems to improve after polypectomy of these polyps. And overall, there has been an improvement. This is one place where studies have shown that there is an improvement with IUI and natural conception following a polypectomy. Although they are labeled a cutoff as 1.5 centimeters, but really, I think any polyp you see in the uterine cavity, we either give a course of OC pills to see if it is shed off during subsequent menstruation, or she undergoes a polypectomy. In case of molar anomalies, as I said, in case of the canalization defects, they have shown a reduced implantation rate, and studies have shown that there is a decreased probability of even the late 8 weeks onwards first trimester abortions and the second trimester abortions with a hysteroscopic metroplasty. In this scenario, doesn't seem to be any difference whether we use a resectoscope or the hysteroscopic scissor. Why I personally use the hysteroscopic scissor is because it's very convenient. Today we go in with the smaller scopes, the 2.9 and the 2 millimeter scopes. So I go in directly with the operating sheath, diagnose the pathology, and snip, cut the pathology. So it makes a welcome change from having to take out the whole thing again, assemble my resectoscope. It's all it makes life so much easier. When you talk about the variations that you see in the uterine septum, you can have a complete uterine septum up to the cervix, involving the cervix and sometimes even the vagina, as we all know. And any type of septum, once you cut the septum, you will have a reduction in the spontaneous pregnancy rate and a concomitant improvement in your term pregnancy and term delivery rates. Whether to cut the cervical septum or not was very controversial, but a lot of studies in the recent past have shown that cutting the cervical septum does not seem to increase the case of the uterine incompetence. So what I do nowadays is that cervical incompetence. So what I do nowadays is that cut the vaginal septum with our open scissors, cut the cervical septum, put in my resectoscope, block the cervix on either side with an Alice or a tenaculum, and keep on cutting until I cut the entire uterine septum. Or otherwise, if you are still in the classical, you want to do the classical mode, put the Foley's catheter on the smaller sides of the two uterine cavities, put your resectoscope from the larger half of the uterine cavity, and in the middle between the fundus and the cervix, cut across till you go to the other side, and then expand the entire uterine cavity. And which type of septum? All types of septum need to be cut, whether less than 1.5 centimeter, more than 1.5 centimeter. There is always an improvement in pregnancy rates. Sometimes when you do a hysteroscopy or you do a 3D ultrasound post metroplasty after a couple of months, you may find a little bump in the fundus. If it's very small, less than 1 centimeter, it does not seem to affect your pregnancy outcomes. This is the new kid on the block, that is the dysmorphic uterus, and which was recognized by the ESHRE and the ESG in 2014. And a recent study by Sanchez et al. Showed that treating doing a metroplasty for a dysmorphic uterus not only improved pregnancy rates, the live birth rates in the recurrent pregnancy loss group, but also in infertile women. And all of us have experienced that when we do a lateral metroplasty for the T shape of the dysmorphic uterus, you have had unexpected and surprising with the number of pregnancies, and most of them, of course, are spontaneous. And this is actually an extension of the study which was done initially in the 2015 period by Dispezio and Dispezio Sardo, and which in their studies, there is a small group, 30 patients. They showed that you had an improvement in pregnancy rates in both infertility group as well as the recurrent pregnancy loss group. And this is the technique that we use for doing it. That is previously we used to use the resectoscope. Sorry, the video is not playing, for cutting the walls, but now I switched completely to the hysteroscopic scissors for doing my metroplasties. Other Mullerian anomalies in case of arcuate uterus, interpretation is difficult because the diagnosis is very, very subjective. Most of us don't do a 3D ultrasound. Most of us diagnose it on the hysteroscopy itself. So it's really difficult to know the actual incidence and whether it really needs treatment. And in case of unicornuate uterus, although we can do some form of metroplasty, what is called as the radial metroplasty, that you cut the lateral walls and give cuts on the anterior posterior walls. Because these are isolated cases, we really cannot justify or judge whether it has had any impact on the outcome of treatment. And why we have to be a little judicious, not overdo things also, I think, because although it's such a simple procedure for most people who are experienced with hysteroscopy, there have been case reports of rupture following a hysteroscopic metroplasty. And this is something we have to keep in mind, not to overdo any procedure. With regards of products of conception, naturally, all these things, like the commonest thing which you find in the practice is retained fetal bones following a previous MTP or a previous spontaneous abortions. Sometimes we can have a cervical ectopic pregnancy mimicking a foreign body or intrauterine pregnancy, and you can have this broken MTP cannula, and which can act as a contraceptive. And of course, naturally, if you have a normal uterine cavity after that, then the pregnancy rates will naturally be better post removal of these foreign bodies. Coming to isthmosil repair, there were two interesting studies. One was which was very selective use of hysteroscopy. The traditional method is do a laparoscopic repair. You go in the laparoscope, dissect the bladder, cut out the scar, and resuture it. But these were two. It's a very interesting technique. That is where you fashion the edges, cut out the edges, and ablate the endometrium that lies in that hollow of that niche. And the first study selected only women where the myometrial thickness of that scar was more than 3 millimeters, and they found good pregnancy rates for conception rates for especially the women who were only infertility, who were proven there was no other cause of infertility. So you could get to only the isthmosil seemed to be a cause, and they found good spontaneous pregnancy rates following this procedure. And the next part was in 2020, wherein they did for everybody with the isthmosil. They did only a hysteroscopic approach, and they were successful in all the cases. And in fact, there was a good amount of pregnancy. 70% of these patients conceived post procedure, and in fact, the scar seemed to be thicker in the follow-up ultrasound. That is, for some reason, once you excise the edges, they seem to oppose and maybe add to the thickness of the scar. Adhesion barriers. All adhesion barriers, whatever you use, the Foley's catheter or the gel or whatever is available, it seems to be better than doing no treatment, and they seem to improve but whether they really when you do a follow-up hysteroscopy, most of the women had lower adhesions compared to the previous picture. But however, they did not seem to have any impact on your pregnancy rates or the pregnancy outcome. So for me, I think the only place where I would use a barrier is when you are doing adhesiolysis, because you are dealing with a poorly vascularized cavity or your multiple fibroids. And the other part is when for a septum and all, I generally do not use barriers. Optimal waiting period before you start your fertility treatment after a hysteroscopic surgery is somewhere about a couple of months, because the healing takes place between 1 to 3 months, like any other cut or any other scar in the body. And I think a couple of months, 2 cycles of OC pills or hormonal therapy, whatever a waiting period is more than satisfactory to give you a good uterine cavity. So to summarize my findings, In case of Mullerian anomalies, there is benefit of surgery, both with regards to implantation and for pregnancy outcome. In case of submucous myomas, hysteroscopic myomectomy seems to improve implantation, but benefit regarding pregnancy outcome, we don't know. The same is the situation with endometrial polyps, improved implantation, but no benefit regarding pregnancy outcome. Intrauterine adhesions, treating them seems to be benefit in case of mild to moderate adhesions, really no benefit in terms of severe adhesions in terms of pregnancy and the pregnancy outcome. Tubal cannulation, useful in case of block the healthy tubes on laparoscopy, possibly because there's just a spasm or a mucus plug. Of course, you have to keep in mind the risk of an ectopic pregnancy. I assure only really makes sense because of the cost. When hydrosalpinx delinking is extremely risky. Otherwise, laparoscopy is the approach. And of course, removal of foreign bodies, because they act as a contraceptive, it is always better, and they will have a pregnancy after if there is no associated infection and intrauterine adhesions. And istomosine, small studies show a benefit, but we really need larger studies. And this is one surgery I fear that we should not overdo it in our enthusiasm. So to conclude my talk, routine diagnostic endoscopy should be discouraged. And with a woman with a normal ovarian reserve, normal pelvic evaluation, endoscopy should be deferred to 3 to 4 cycles of IUI or ovulation induction. And in those requiring IVF, I think a good radiological evaluation will obviate the necessity of an endoscopic evaluation. And hence, hysteroscopy or a hysterolaparoscopic procedure for these women should be decided on a case-to-case basis. Most of the uterine cavity abnormalities can be tackled with a hysteroscopic procedure. Maybe the only caveat will be probably large fibroids, where you will have to decide between laparoscopy or the hysteroscopic approach. And in most cases, you will be successful in your procedure. But as I said, we have to be careful in selecting the patients for these procedures, and because we really don't know even now that whether how much these our procedures contribute to the fertility outcome. And a simple Foley, wherever required, a simple Foley's catheter with estrogen is of potential benefit. I think in the future, 3D ultrasound will replace relook hysteroscopy in following most of these procedures. So I would like to thank you all for a patient hearing.
Thank you, sir. Thanks. Very nice presentation. Very elaborate. Everything you have covered. So there is one question. Is there any role of platelet-rich plasma after extensive adhesiolysis?
No. It doesn't work. It is as good as putting a catheter or your Foley's catheter and giving you hormone therapy. Frankly, as of now, there is no evidence that it works better than any of these.
Okay, sir. Thank you.
Thank you.
Thank you, sir. Yeah. Thank you, sir, for your presentation. Now, actually, it's very unfortunate to tell you that one of our speaker of the present CME was actually not with us, late Dr. Praveen Rathod. He was a senior consultant, gynecological oncology and laparoscopic surgery. Sir was MD and National Premier Institute, Chandigarh. He did his MCH from very well-known institute, Kidway Center, Cancer Institute, Bangalore. Sir was laparoscopic training in the best institute and research center, Bangalore. And he was international fellow. He had an international fellowship in gynecological oncology from USA. He had demise on last 9th of May. I would like to call Dr. Vivek Salunke, sir, to just say a few words about him. Vivek, sir. Hello.
Hello.
Vivek, sir.
Hello.
Yes, sir.
Can you hear me?
Yes,
Yes,
sir.
sir.
Yeah. Hello, everyone. Good evening. With a very heavy heart and very sad news, which just Sachin shared with us, I would like to speak some words regarding Praveen. When Santosh first called me that oncology, I told him I can take a talk, but then it would be always very informative for our all delegates and for us also if Praveen talks about it, because always he was a great academician, great friend, and
we would always look forward for his talks in all the conferences. So to speak something about Praveen, he's a great friend, he's a very skilled gynec oncosurgeon. His background was he came from a very small town in Bijapur, and he was the first gynec MCH gynec onco in South. Very humble, very friendly, and always eager to teach. We could talk to him any time without hesitation regarding our cases, and he would discuss in length, go through the reports and guide us time and again. He was always encouraging to his juniors, very interested in minimal access surgery, because he was the one who taught us retroperitoneal para-aortic lymphadenectomy and para-aortic lymphadenectomy also. So we got trained with him in Kidwai Memorial Hospital in Bangalore, where he was heading a unit. His goal is going to be a great loss to the field of gynec oncosurgery, which will take time, long time to fill. So I think we have lost a very great surgeon, and
okay, thank you, sir. I can understand your emotions. So for the tribute of his work, today we are going to play one of his video of how to go for the laparoscopic staging of the early ovarian cancers. Can everybody see the video?
The screen is not visible. You have to share the screen.
The screen is already shared. Wait, just wait.
No.
Wait.
Yeah.
Yeah. Now?
Yes,
we can.
Audio is not on.
Sir, audio is little low only for this.
Audio is not there, audio at all.
We can't hear anything.
Maximum audio. Santosh, audio ऐकू येते?
No, can't hear.
Okay, can you put from your this one if possible?
मला लिंक पाठव ना सचिन.
Okay.
As they're trying to set up the video, if anybody has any questions regarding the previous talk, they can ask Dr. Nagendra.
मला लिंक पाठव ना.
संतोष ऐक ना. संतोष. Hello.
Is it audible now?
No, I think Santosh, the audio is very less. I think Dr. Vivek sir can narrate the video.
1 minute. I just,
No, you can give moderation.
can I have his radical hysterectomy video with we play that?
1 minute.
Yes, sir.
Yes. Huh?
Yes, sir. Go ahead. Yes, sir.
Yes, sir. Please.
Santosh, stop your screen sharing.
Stop. I will stop. Yes.
Yeah, and let Vivek sir, so you can start shares.
Hello.
Yes, sir. So please share the screen first.
Yeah. 1 minute. I just share the screen.
Yes,
Yeah.
sir.
Yeah.
Type 1, type 2, type 3 radical hysterectomy.
Can you see the
Type
screen?
1
No,
is
sir, not. Now you can
preserving
see the screen.
pericervical fascia.
Hello.
The video is not. Yeah, now you can see the video.
This video demonstrates
See, this video was prepared by Praveen for our IIG website. It was a very good video. It was a 20 minutes video. But we couldn't publish it. So I am just playing this. It
Yes,
has
sir.
audio also.
Yes, sir.
This video demonstrates laparoscopic nerve sparing radical hysterectomy with block pelvic lymphadenectomy for early stage cervical cancer.
Can you hear?
Yes,
Yes,
sir.
sir.
We have type 2, type 3 radical hysterectomy. Cervical fascia. Type 2 is parametrium medial to ureter. Type 3 is lateralizing ureter and dissecting the parametria. This is a specimen of type 3 radical hysterectomy, where you can see 3 cm of parametria and 2 cm of vaginal length. Currently, we follow Carlo-Marok classification for radical hysterectomy. Type C1 radical hysterectomy, dissecting parametrium in 3 dimension, ventral, lateral, and dorsal. The length and vagina should be 1 to 2 centimeter in length. The pelvic organs are supplied by sympathetic T10 to L2 and parasympathetic S2, 3 and 4. It's not important during radical away from the uterocipral ligament during Okabayashi space, and the splanchnic nerve is preserved by dissecting below the uterine vein and lateralizing them. Thus, hypogastric and sympathetic nerve form a relation that is T shape or Y shape. Then they go further, joining together. Early stage cervical cancer is a concern after publication of LACC trial. It is associated with higher recurrence and lesser survival compared to open surgery. These things have to be discussed with the patient before taking them for surgery. The MIS is not a poor prognostic factor in patients with lesion size less than 2 centimeter. These subset of patients are maybe the ideal candidate for MIS in early stage cervical cancer. These are the steps of type C1 radical hysterectomy. To start with, entry of the retroperitoneum, creation of the spaces, identification of the autonomic nerves and preservation of the nerves, later resection of parametria, removal of the specimen, and en bloc pelvic lymph node dissection. The first step is identification of the triangle formed by the round ligament, IP iliac vessels, cutting the round ligament as laterally as possible, then entering the broad ligament and cutting the transverse fibers of the broad ligament. You can see obliterated umbilical artery here, which is dividing the paravesical space into lateral part, that is also known as obturator space, obturator fossa, and the medial part. So paravesical space is divided by obliterated umbilical artery into medial and lateral space. Further, cutting the peritoneum upwards almost up till the appendix. Here you can see ureter entry to the pelvis. Ureter crosses the common iliac artery at the level of bifurcation and enters the pelvis. Between the internal iliac artery laterally, medially, the ureter and the rectum, there is a pararectal space. Most of the pelvic spaces are avascular, and we can see a nerve fiber there running in the pararectal space 1 to 2 centimeter below the ureter, that is hypogastric nerve. T10, T11, L2, pararectal space as written here. Splanchnic plexus, S2, S3 here, you can see they come from the lateral pelvis. They are usually below the uterine vein, and the uterine vein is below the uterine artery. This is a neurovascular anatomy. Splanchnic nerves and hypogastric nerves and the deep uterine vein. Further, this hypogastric nerve and splanchnic nerve join together in a Y-shaped manner, forming inferior hypogastric plexus. This inferior hypogastric plexus runs in dorsal parametria laterally below the uterine vein, further to the urinary bladder and the vagina. Preservation of These nerves is very important for good bladder function and sexual function. After cutting the uterine artery, we can see the deep uterine vein, which is below the uterine artery here. And the splanchnic nerves are below the uterine artery, coming from the lateral pelvis, hypogastric nerve joining them and forming a inferior hypogastric plexus. The next step is creation of rectovaginal space. Opening the peritoneum just anterior to the rectal fat. Identifying the ligaments, then resecting the parametrium. This space is very important to take the vaginal length at least 1.5 to 2 centimeter. Margin is needed. Radical step coming. The next step is cutting the UV fold anteriorly. The UV fold peritoneum is cut here. Then we need to dissect it a little closer to the bladder to give a good anterior margin. The anterior margin is here, just preserving the pericervical fascia. So in routine hysterectomy, we do a intrafacial. We try to dissect this fascia and push along the bladder. But in radical hysterectomy, you can see here the pericervical fascia is preserved. So therefore, we need to be little closer to the bladder than usual. This is the normal hysterectomy. Here is the during radical hysterectomy. We will be little closer to the bladder. So pericervical fascia preservation is important. So this is the fascia over the cervix has to be preserved. And to take a good vaginal length anteriorly, we need to further dissect the bladder down. That is, we have to mobilize the bladder further down and we have to create vesico-vaginal space. Vesico-vaginal space. As we create rectovaginal space in the posterior side of the uterus, here is the anteriorly, we create vesico-vaginal space. Has to be created at least 2 to 3 centimeters below the cervix to get a good vaginal length. You can see this is vesico-vaginal space. Then coming to the anterior, that is ventral parametria, also known as anterior vesico-ureteric ligament. Here you can see this part is just below the bladder pillars, and this is also described nowadays as ventral parametria. This is the ventral parametria, that is also known as anterior vesico-ureteric ligament. Here you can see on the other side, that is the left side after dissection, taking the ventral parametria. So we have to dissect parametria in 3 dimensions: ventral parametria, posterior parametria, that is uterosacral ligament, and then the lateral parametria. Here you can see the obliterate anterior divisions of internal iliac artery, that is a superior vesical artery is preserved here, and then this is the left uterine artery is ligated with harmonic in a sandwich technique, rotating the blades. So again, we can dissect. Next step is creation of the Okabayashi space. Okabayashi space is between the posterior lip of broad ligament and the ureter. Going further down between the ureter and the broad ligament, we identify the hypogastric nerves. Here you can see these are hypogastric nerves on the right side. Again on the left side, Okabayashi space, you can further dissect down and identify the hypogastric nerves and lateralize them. This is the left Okabayashi space, and the hypogastric nerves are separated from the uterosacral ligament here. After we clear the spaces and identify the nerves, the next step is ureteric dissection. In type C1 and type 3 radical hysterectomy, we have to dissect the ureter, de-roof the ureter, lateralize it, then create a paravaginal space and take at least 2 to 3 centimeter of parametria, cutting the uterine vein at the level medial to the inferior hypogastric plexus. Here you can see the active blade is away from the ureter, and the ureter is being dissected away. The ureter lies on the deep uterine vein. Here it is shown there, deep uterine vein. The deep uterine vein is joined by the vesical vein there. So below the deep uterine vein, these are the nerves, sympathetic and parasympathetic nerve forming inferior hypogastric plexus. Once we identify them, we can further dissect the anterior vesicoureteric ligament and deal with the ureter completely till bladder entry. De-roofing of the ureter. Once we de-roof the ureter, there is few fibers which will be holding the ureter towards the vaginal angle. These things needs to be dissected. This is also known as posterior vesicoureteric ligament. Once we dissect this, cut this posterior vesicoureteric ligament, ureterovesical junctions further moves away from the vaginal angle. This space is known as Yabuki space. Here is the uterine vein and the ureter. This is the Yabuki space. This is also known as paravaginal space. Creation of this space is important to take good paravaginal length. Now this is the posterior, the dorsal parametria, that is uterosacral ligament. Here you can see the autonomic nerves are lateralized, and this is a uterosacral ligament. And uterosacral ligament, at least 2 centimeter margin can be easily taken after creating good pararectal and Okabayashi space and paravaginal space. Here you can see uterosacral on the right side is cut and the nerves are preserved just lateral to the uterosacral. This is length, almost 2 centimeters of dorsal parametria. The dorsal parametrium on the left side, left uterosacral ligament. Going further down, separating the hypogastric nerve from the uterosacral and cutting the dorsal parametria. During dissection of dorsal parametria, few fibers of nerves coming to the uterus will be cut, but the fibers which will go to the bladder will be preserved. Now, resecting the lateral parametria, that you can see that is a uterine vein just in the dorsal parametria. That is a few nerves which are coming to the uterus will be sacrificed, but the nerves going to the bladder will be lateralized and preserved. This is the uterine vein resection just medial to the hypogastric and inferior hypogastric plexus. This is very important. We have to dissect the uterine vein, that is the nerve fibers, hypogastric nerve forming IPH. You can see the stretch. The nerves going to the bladder are preserved and they are just running below the ureter in the dorsal and lateral parametria there. Once we do that, the remaining steps are easy, and resection of the vagina. So vaginal resection is done here. Make sure we get at least 1.5 to 2 centimeters of vaginal length in type C1 radical hysterectomy. Section of the vagina and remove you can see good vaginal length all around resected. After finishing this, we have to proceed further for N block pelvic lymph node dissection. So to begin with, generally I start from the ureter, where the ureter is crossing. You can see here where the ureter is crossing, common iliac division there. To begin with, start the node dissection from here. All the node dissection in a single chunk, that is N block. Dissection from lateral to medial in a single chunk. That is the division of the common iliac, giving rise to internal iliac artery and external iliac artery. All the fibrofatty tissue along the iliac vessels will be removed. N block pelvic lymph node dissection. So there is a clearance from bifurcation of iliac node. These are internal iliac nodes. There you can. Once we finish the diagonals, the same chunk of nodes will be attached to the obturator nodes here. The whole block has n block dissection. So the lateral dissection can be very well done by this method, that is dissection between the iliopsoas muscle and obturator internas, and retracting the iliac vessels medially. Here you can see the obturator fossa and there's a obturator nerve. Obturator nerve is identified here, and all the nodes above the obturator nerve is cleared. You can see all the nodes over the obturator nerve is cleared. Once we do the lateral dissection of lateral attachment, removal of the remaining part of the node is very easy. After the dissection, you can see the anatomy: internal iliac vein, internal iliac artery here, that's the obturator nerve, obturator fossa. All the nodes are cleared. It's en bloc pelvic lymph node dissection. Similarly, we can do the same thing on the left side also. Here also you can see all the obturator nerve and iliac vessels. After the dissection, you can see the relation of parametria here: uterine vein, vesical vein, joining and forming an internal iliac vein. Then the splanchnic nerve is below the uterine vein. Ureter is medial to it. So these are the steps of radical hysterectomy. I hope it is clear to you all. You may contact me on this email and phone number if you have any doubts. Thank you very much.
Thank you, sir.
Thank you, Rahul.
Thank you, Dr. Vivek, sir, for your contribution, and really thank you for presenting this video to all of us.
Thank you so much.
Now, moving to the next talk, we have got Dr. Rahul Vani. I don't think he's requiring any introduction because he's our president, Navi Mumbai Obstetrics and Gynecological Society. Sir is an honorary consultant at Mathadi Hospital Trust, Navi Mumbai. He's an obstetrician and gynecologist at Archana Maternity Hospital, Navi Mumbai. He is a medical legal consultant at B&S Medical Legal Consultancies, member of Ethics and Medical Legal Committee, FOXY, member of State Oversight Committee of HIV and AIDS, and he is lead assessor of Manyata FOXY project. Now, after seeing this slide, you can see the Taj Mahal and Mumtaz, and you can see the PPH. So the talk of today's talk is nothing but the new drug in the medical management, that is carbetocin. Over to you, Dr. Rahul. Thank you, sir. Please unmute yourself, Dr. Rahul, sir.
Yeah.
Please, yeah.
Can you hear me now?
Yes, yes.
Yes, yes.
So, is my screen shared already?
No.
Not yet.
Yeah. Oh, I think so. No?
Not yet.
Okay. Just a minute. I think it is shared already. It is shared already, I think.
Yeah,
so.
yeah,
Now you can see.
I can't see my own slides.
Now you have to select the PPT for screen share. I think you have selected the desktop.
Is your presentation open on the desktop?
Yes, it is open. I have already shared, but somehow I'm seeing only the speakers. I'm not seeing my own slides.
You stop share and again restart it.
Okay, I'll stop share and I'll restart again.
Yeah.
Okay. Now, can you see my slides?
Yeah, it's seen.
Yes.
Very well.
Okay. Okay. Now, I'll be today's talk for me is carbetocin, the new drug in the management of PPH. I thought this was a very new drug, and it is an important drug in our management of PPH. And PPH is one thing which is not which is causing a high mortality in India. Now, one of the leading causes of mortality in India, and almost 38% of maternal mortalities in India account from PPH. So we all know what is postpartum hemorrhage. In a vaginal delivery, if the blood loss is more than 500 ml, or if in a cesarean section, if the blood loss is more than 1000 ml, and any amount of blood loss within 24 hours after birth, which causes increasing pulse rate or falling blood pressure. Now, suppose the patient is already anemic or the patient is pre-eclamptic, then the intravascular volume is less, and the patient might not tolerate even these small amounts of blood loss, which to define it as PPH. And, this still shows some hemodynamic changes. So primary PPH is the which occurs in the within first 24 hours of delivery is called primary PPH. Anything which is after 24 hours to 6 weeks of delivery is called as secondary PPH. And we all know the 4 T's which cause PPH: tone, trauma, tissue, thrombin. And as we see, the most common cause of atonic PPH of PPH is the atonic uterus. Almost 70% of causes of postpartum hemorrhage is atonic uterus. So what are the risk factors for PPH? Like a patient who is already anemic and having preeclampsia, as we discussed earlier, a patient having prolonged labor, grand multipara, augmented and precipitate labor, history of PPH in the past delivery, over-distended uterus like macrosomia, twins, polyhydramnios, any instrumental delivery, and chorioamnionitis. All these are risk factors for PPH. Now, since PPH is a important subject and it causes a lot more of mortality, WHO gives a lot of importance to PPH, and there are various publications which come out of WHO almost every 2 years. Now, World Health Organization recommends active management of third stage of labor for prevention of postpartum hemorrhage. So, active management, what does active management include? It includes the administration of uterotonic within 1 minute of delivery of the child, controlled cord traction. This is only if a skilled birth attendant is available, only then controlled cord traction should be given. Palpating the uterine tone, and if the uterine tone is atonic, only then uterine massage. So if you see, what is most important in third stage of active management of third stage is the giving the uterotonic within 1 minute of delivery. And it is said that almost it reduces the incidence of postpartum hemorrhage by 50%. If you do this, if you administer an uterotonic within 1 minute of delivery, the rate of PPH reduces by almost 50%. Now, PPH after cesarean deliveries. Now, as we all know, there is exponential rise of number of cesarean sections, mainly for safeguarding the mothers as well as the baby's health. The incidences of PPH are seen more in cesarean sections. In cesarean sections, the PPH is to the tune of around 6%, while in vaginal deliveries, the PPH rate is around 2 to 4%. So PPH is more likely to happen after cesarean section as compared to vaginal deliveries. and therefore it is common practice to give a uterotonic drug following delivery of the neonate during cesarean section. And it is a common practice to give a uterotonic drug even after a normal delivery. This I have taken from the International Journal of Anesthesia Consensus. So they are focusing on cesarean section, but it is a common practice to give a uterotonic even after a normal delivery. So the international consensus statement on the use of uterotonic agents during cesarean section, published in 2019, says uterotonic agents like oxytocin or carbetocin are recommended as routine administration immediately after the delivery of the baby during cesarean section to prevent postpartum hemorrhage. As I said, it is administered with cesarean section as well as after the vaginal delivery. This decreases the risk of postpartum hemorrhage considerably, almost to a 50% rate. Now, what are the uterotonic drugs available? I don't need to tell you all about all these drugs, but the new addition, I'll focus on the new addition. Oxytocin and carbetocin are the first line agents. Means carbetocin has been considered as equivalent to oxytocin and can be replaced with oxytocin. It is considered as a first line agent as oxytocin, and the rest of them are the second line agents like ergometrin, methyl ergometrin, prostaglandins, misoprostol, carboprostol. The second line agents in prevention of PPH. Now, oxytocin still, even the WHO considers the oxytocin as the gold standard treatment for the prevention of PPH. But there are certain limitations with oxytocin, and these limitations are oxytocin has a half-life of 4 to 10 minutes. That means it is a short-acting drug. Duration of action is only for 15 to 20 minutes. And sometimes we need to administer it as a continuous intravenous infusion to attain the sustained uterotonic activity throughout the surgical procedure or immediate postpartum period where we are treating an atonic PPH. It has to be transfused over a period of time. Since it is a short acting, it is not a long acting drug. And oxytocin causes receptor desensitization. Now, if you have used oxytocin as a drug for augmentation or induction of labor, it is seen that when the uterus is exposed to oxytocin for a period of almost 4 to 5 hours, then the contractility of the uterus to oxytocin reduces markedly. In an experiment, they have shown that the uterine muscles, almost 50% of the muscles do not respond to oxytocin given post-delivery if oxytocin has been used during the antenatal or during the intrapartum period for augmentation and induction. Now, in different studies in international bodies and trials have used different doses of oxytocin. Some have said 5 units intravenous, some saying 10 units intravenous, some saying 10 units intramuscular. So there is a lot of variation in the doses which have been told or which have been studied. And oxytocin is a high alert medication. Now this is mainly because for its antenatal use. Because if you start an oxytocin drip and it is run unmonitored or it goes fast, then antenatally it can cause problems. So that is why it is an high alert medication, not more so for the post-delivery part, but for the antenatal part. It has to be monitored properly before when you are inducing a patient or augmenting a patient with oxytocin. Now, uterotonics, all the uterotonics we know, like the oxytocin or methergin or prostaglandins, they are heat labile and they need to be stored and transported at 2 to 8 degrees centigrade. So do we have something which can overcome these limitations, which is a drug which is longer acting, which has only a single dose administration with no variation in dosage regimes. It is devoid of repeated administration, ease of one-time administration, superior or similar efficacy to oxytocin. It is some drug which is devoid of receptor desensitization and which has a similar side effect profile over oxytocin, because oxytocin is considered as the most safest drug among the uterotonics. So do we have any replacement for this? And some drug which is heat stable. Now, this is what is carbetocin. Now, carbetocin is a synthetic analog of oxytocin, which is structurally very similar to oxytocin, but there are minute changes in its structure. So these structural modifications increases the half-life of carbetocin and it has a better pharmacological long-acting effect on the uterine myomet. Stability of the molecule. Now, right now, the carbetocin molecule is available in heat labile form also and heat stable form also. So the heat stable form is stable at 30 degrees centigrade for 3 years and 40 degrees centigrade for 6 months, 50 degrees centigrade for 3 to 6 months, and 60 degrees centigrade for 1 month. And the bioavailable dose is 80%. So there is a heat stable formulation of carbetocin, and carbetocin works through the oxytocin receptors. And that is why when we talk about oxytocin desensitization, now there could be desensitization because if you have used oxytocin before during the antenatal period and the oxytocin receptors are blocked, then probably carbetocin would have a similar effect, or the carbetocin effect, drug effect would be a little less. This has not been studied as yet. I am just applying my logic. But carbetocin would still have a better effect than oxytocin because it is a longer acting, it is a stronger acting, and so that is why, logically speaking, it would have a better effect than oxytocin. It is a uterotonic and it is anti-hemorrhagic also. So now, if you see carbetocin, its half-life of carbetocin is almost 40 minutes. That is 10 times more than oxytocin, where the oxytocin half-life is only 4 minutes. Duration of action of carbetocin is longer than intravenous or intramuscular oxytocin. It was found that a single intravenous bolus injection of carbetocin was at least effective as 16 hours of continuous oxytocin infusion. And carbetocin does not need repeated administration, single dose. There is no dose variation. There's single dose of carbetocin, which is found to be effective to control PPH. And unlike oxytocin, which has been studied over various doses. So carbetocin is superior over oxytocin with respect to its pharmacologic content and pharmacologic action, and its using simple single dose administration. Now, what are the contraindications for carbetocin? Epilepsy, eclampsia, and hypertensive patient, it has to be used in caution. And these contraindications are mainly because it has been not studied as widely as it when it is studied. More probably these contraindications would also go, as these contraindications are not for oxytocin. So carbetocin is very similar to oxytocin, and as the studies progress, probably these contradictions will also go. Now, the leaflet also says that it is contraindicated in patients having renal disorders and liver disorders. That also is mainly because it has to be studied further to see its efficacy and safety in these patients. Now, it is absolute contraindication is carbetocin cannot be used before delivery. It cannot be used for induction of labor. It cannot be used for augmentation of labor because it is a long-acting drug and it will cause tetanic uterine contractions and may cause respiratory distress to the mother as well as the baby. The carbetocin has been included in the WHO essential medicines list as a uterotonic for prevention of excessive bleeding during childbirth. Mind you, the carbetocin, which has been included in the WHO model list or the essential list of medications, is the heat stable formulation and not the heat labile formulation. Now, this is a publication from the WHO which has come out in 2018. Now, this is a very good publication, and I would probably forward this to everyone after this talk or tomorrow. Everyone should go through this publication, where it has and this publication is only for prevention of postpartum hemorrhage. It does not talk about treatment of atonic PPH. It talks about only prevention of postpartum hemorrhage. So basically, first line drugs. Now, if you see this context in which the efficacy and safety of uterotonics for PPH. So in context of efficacy and safety of uterotonics for PPH, the WHO has found that oxytocin and carbetocin are very safe for delivery, for using it in all births as primary preventive uterotonic. The use of oxytocin 10 international units intramuscular intravenous is recommended for prevention of PPH for all births. Now, similarly, use of carbetocin has also been recommended for prevention of PPH for all births, but this is a context-specific recommendation saying that the cost, if the cost is comparable to the other uterotonics. Now, if you see carbetocin, which is available in India today, is the MRP is around 350, and the hospital is supplied at around 280 or something, at the rate of 280. So it is not very expensive. And if you go on to the next context, now carbetocin is recommended by WHO as an effective uterotonic in its 2018 guidelines. And one more important thing is carboprost is not recommended as a primary prevention drug because of its side effect profile. The oxytocin and carbetocin have similar side effects profile, but carboprost has a larger side effect profile with diarrhea, vomiting, severe vomiting, and all those things. That is why it has not been recommended as a primary prevention drug. Now, if you go on to the next chart in the same publication, what is the choice of uterotonics for PPH prevention? So the first line of choice remains as oxytocin, but what they have said is, and which is very important for our setting, is where oxytocin is unavailable or its quality cannot be guaranteed, then other injectable uterotonics like carbetocin is appropriate for primary prevention. And now why I'm stressing on this fact is because oxytocin, though it is relatively inexpensive and widely available, it requires refrigeration and transport and storage at 2 to 8 degrees centigrade. In setting where this cannot be guaranteed, the quality and effectiveness of oxytocin may be adversely affected. In these situations, another effective uterotonic may be considered. This is as a part of justification. If you go through that document, this comes as a justification of use of other uterotonics, or what is the context where they say where the quality of oxytocin cannot be guaranteed. It is this context which they say if the cold chain management is not very effective. If you see, if you ask your sisters how is oxytocin delivered to your hospital, they are delivered just like that, without managing the cold chain. If we know in the recent past, there was oxytocin shortage, and we were all hunting where we could get pitocin, and I found one distributor who had a stock of pitocin, so I personally went there to get the oxytocin, and I found that he had stored it just on the shelf. And when I asked him why is it not in the refrigerator, he said, no, we just removed it from the refrigerator. But the ampoules were not cold; they were just as warm as any other drug which is kept in the shelf. So the cold chain management of the uterotonic drugs, I did a small survey in our hospitals. I had sent it to 5 hospitals asking them how oxytocin is delivered. I got only one response from one hospital where they said after repeated hammering, they are now delivering it in a cold chain. But we don't know how the distributors are keeping it and how it is transported and stored. Now, this is also the same document which gives the justification of use. The carbetocin has similar desirable effects compared with oxytocin, though it is and thought it is likely to be superior to oxytocin in reducing PPH. There are 41 fewer events per 1,000 women. Use of additional uterotonics, which was required in lesser women after use of carbetocin, and blood loss, 81 ml blood loss lesser than other patients where other uterotonics were used. So there is no clear difference between carbetocin and oxytocin in terms of undesirable effects. But with the balance of effects, probably carbetocin is favorable. This is included in the document which has been published by WHO in its 2018 recommendations. Now, carbetocin has been studied throughout the world, and the clinical trials have been done after vaginal delivery as well as after cesarean section, and almost all the trials for vaginal delivery as well as cesarean section say that the carbetocin is better acting than oxytocin. Now, in this study, intravenous carbetocin versus intravenous oxytocin for atonic postpartum hemorrhage after normal delivery in high-risk singleton pregnancies. A triple blinded control study was done where they used 100 micrograms of carbetocin, which was given IV slowly over a period of 1 minute, and 5 units slow IV was given over a period of 1 minute. And they measured the outcomes with the incidences of atonic PPH, postpartum blood loss, additional uterotonic requirement, adverse events. And what they found was carbetocin was superior in every aspect of atonic PPH or postpartum blood loss or the need of additional uterotonic drugs. And almost all the studies have shown a similar response or a similar outcome. So intravenous carbetocin is more effective than intravenous oxytocin, and prevention of atonic PPH among pregnancies with at least one risk factor. Here, the patients studied were with one risk factor. Similarly, in another study, and again an open-labeled randomized control studies where they compared carbetocin with oxytocin, similar outcomes, but here they had used 10 units intramuscular oxytocin. The results were very similar. The primary PPH was lesser in carbetocin group, massive blood loss was lesser, immediate blood transfusion requirement was lesser, and average amount of blood loss was also lesser. So they concluded that the carbetocin appears to be a more effective drug in active management of third stage of labor. Now, prevention of PPH following cesarean delivery. Here also the carbetocin, misoprostol, and oxytocin, all three were compared in elective cesarean sections where carbetocin single dose, it is available only in one dose, 100 micrograms. 10 units of oxytocin were given intravenous. There is a latest publication of WHO which has come out in November 2020, where there is a context-specific recommendation for oxytocin, where they say if the patient has an IV line, then 10 units IV oxytocin is better than 10 units intramuscular oxytocin. It was compared with 400 micrograms misoprostol also. And the outcomes which are looked for, occurrence of uterine atony requiring additional uterotonics. Here also the results showed that carbetocin performed better than the other uterotonic drugs. And it has similar side effects to oxytocin and lesser side effects to the other uterotonics. Now, prevention of PPH following cesarean delivery, where it was done with in cases of general anesthesia, where isoflurane induced uterine hypotonia was given, such as in twin pregnancies and this. Here also they found that carbetocin was better performing than oxytocin. You can see the charts everywhere. It is seen that carbetocin has performed better than oxytocin with regards to additional uterotonics or postpartum blood loss, patient requiring blood transfusion. Now they have also studied carbetocin versus combination of drugs like oxytocin, misoprostol, and even in these studies they have found carbetocin to be better effective than the combination. Because this misoprostol, and they have more side effects like shivering, fever. So carbetocin has a better side effect profile, very comparable to plain oxytocin. Again, this study with carbetocin and combination of oxytocin plus argometrin. So almost 200 women scheduled for elective cesarean section. In one arm, 100 micrograms carbetocin was given IV, while in the other arm they give oxytocin and argometrin, and the outcome measures were uterine tone, need of additional oxytocin, and blood loss. And what they found was carbetocin performed better even with other than combination of oxytocin and argometrin. So carbetocin is a preferable drug in the reduction of postpartum blood loss and more safety in side effects of drugs than methyl argometrin. This is a combination of carbetocin with argometrin. There was a Cochrane review, and the Cochrane review also came to a similar conclusion that carbetocin resulted in statistically significant reduction in the need for therapeutic uterotonics compared to oxytocin. Carbetocin is better effective both in vaginal deliveries and cesarean sections with lesser side effects. This is once what we talked about was only in the prevention of PPH. I found this is again the reduced pain perception with carbetocin than oxytocin in cesarean delivery. Almost all these clinical trials have proven that carbetocin is a more effective drug with similar side effects to that of oxytocin. Here, carbetocin versus oxytocin was studied in cases of severe preeclampsia, and they found that there was no severe side effects with carbetocin, and carbetocin performed better than oxytocin or IV infusion of oxytocin. You can see the results. The carbetocin in the need of additional uretrotonics or blood transfusion performed better than the oxytocin group. Carbetocin is an appropriate alternative to oxytocin for the prevention. If you compare carbiprost with carbetocin, carbetocin is a first-line agent for PPH. Carbiprost is a second-line agent in PPH management. It is not recommended for primary prevention by WHO, but carbetocin has been recommended for primary prevention in PPH. Carbiprost has a lot more severe side effects than carbetocin. Carbiprost again is contraindicated in asthma, and in asthma carbetocin has to be used with caution because it has to be studied more. Carbetocin is still to be studied extensively to see the efficacy and safety in these patients. So if you see management of third stage of labor during vaginal delivery in patients with singleton pregnancy or with high risk pregnancy, carbetocin has performed better. Even in PPH prevention in cesarean deliveries, whether it is elective cesarean section or with a high risk cesarean section, in patients with twin pregnancies, it has performed better. Now, I had a chance of using carbetocin in 2 of my patients. One patient with PPH, atonic PPH post delivery. She was a dentist doctor. Post delivery, we used everything. We used oxytocin, we used methergin, we used prostaglandin, carboprost, but the continuous trickle was there. Though the bleeding was not heavy, the continuous trickle was there. So though carbetocin at present is not recommended for treatment of atonic PPH, we took a chance and we gave this carbetocin, and the patient settled down within 5 to 10 minutes of injection of carbetocin. Now we really don't know whether it was the previous drugs which were administered which caused that, or or carbetocin had its effect. But the effect came after injection of carbetocin. So as there are 2 studies where carbetocin has been used as a management in atonic postpartum hemorrhage. They found that blood loss was lesser in carbetocin group, and there was no significant difference in major PPH than other uterotonic. So carbetocin can be used in selected cases if it is not responding to your regular management in atonic PPH, in treatment of atonic PPH. There is also a study from the Fetal Medicine Foundation where they have studied carbetocin in management of atonic PPH, and they have found that it is similarly effective like the other uterotonics. It might not be as better effective than other uterotonics, but it is as effective as the other uterotonics. Now, in carbetocin has been studied in India also in this champion trial where 10 countries were participating. Now here the heat stable form of carbetocin was used. Now heat stable carbetocin can be given intramuscularly also. So this trial studied intramuscular carbetocin with intramuscular oxytocin, 100 micrograms of carbetocin and 10 units of oxytocin, and compared the efficacy in prevention of hemorrhage. This was carried out across 23 centers in 10 countries. There were some centers in India. The list is here. And what they found is carbetocin is not inferior to oxytocin. So intramuscular carbetocin is not inferior to intramuscular oxytocin. That was their conclusion after this trial. Now, carbetocin was also mentioned in AICOG 2019, and there also they had brought out this point of cold storage. Carbetocin the 2 to 8 degree centigrade storage of the uterotonics, which is not very effectively managed in India with so many power shutdowns and this. So the efficacy of the potency of the uterotonic drugs gets reduced. Now, carbetocin is 100 micrograms per ml. It is a 1 ml solution which has to be given slowly over a period of 1 minute. It can be given immediately after delivery within 1 minute, vaginal delivery, and during cesarean section after delivery of the baby. It can be given as a slow IV bolus 1 ml. So, to summarize, carbetocin has been found to be superior with oxytocin with respect to prevention of PPH, blood loss after delivery, need of additional uterotonic agents, deviation in hemoglobin levels, need for blood transfusion, and it has been also found superior to other uterotonics, and since it has a better side effect profile comparable to oxytocin. So carbetocin, the most efficient uterotonic, which was most awaited, has arrived in India, and with the only disadvantage of the current formulation is it is only for IV use and it is not heat stable. So our sincere request to the company which has brought in carbetocin into India is to get a heat stable formulation as early as possible. And till an heat stable formulation is available, promise of stringent cold chain management right from the manufacturing unit till the delivery of the hospital. We need a promise that they will deliver this in a cold chain to be more effective than the other drugs. Otherwise, it will have the same effect as the other drugs, and the whole advantage will be lost. Thank you, Blisson, for supporting this CME and for bringing in carbacin in India. So, is any of the this Blisson people around here? So, we need a promise from you. We need a promise from you that you will maintain the cold chain for carbetocin till an heat stable formulation is available.
Good evening, everyone. I'm Parag, marketing manager from Blisson. And firstly, I would like to thank Dr. Rahul sir for having a wonderful presentation. And as he's talked about the stability of the carbacin, so I would like to let you know that our carbacin, which is heat stable, and we have applied for the patent also for the same heat stability, but as a precautionary measure in the initial stages we are recommending it for the storage between 2 to 8 degrees centigrade, and this storage we are also maintaining this cold chain right from manufacturing to supply till you. All the stockists are maintaining carbacin, and our MRs are ensuring that the stock is been maintained in the cold chain between 2 to 8 degrees centigrade, and you can also confirm it when we will be supplying it to you. We are currently taking the orders also, and you can also check at any time with our stockists. So that assurance will be there from you, from our side to you. Also, I would like to tell everyone that after a certain data is available within a couple of months, we will definitely come with, we will remove this compulsion of cold chain management, and it will be stable as international brand at 30 degree.
Okay, thank you, Parag. Thank you. We can move
Thank
on
you,
to,
sir.
if there are any questions, I will answer them, or we can move on to the next topic.
Yeah, I think there are no questions as such.
Okay.
Yeah, we can go to the next talk. Thank you, Dr. Rahul, for the very elaborate theoretical and as well as very practical talk about the carbetocin, the new molecule in management of PPH. Our next speaker, Dr. Aniket Kakade. Sir is a consultant and fellow in high-risk pregnancy and critical care obstetrics. He is a professor at Bharati Vidyapit, Pune. He is a national faculty for high-risk pregnancy and critical care obstetrics, leads the dedicated obstetrical HDU at Bharati Hospital, Pune. He is UG and PG teacher with 30 publications on his name in national and international journals. So his talk of the today is the COVID management, mild to moderate cases of COVID during pregnancy. Over to you, sir. Dr. Ani.
Thank you, Sachin.
You can share your screen.
Yeah. Yeah, can you see my screen now?
We can see your screen, sir.
Yeah, and I'm audible, I hope.
Yeah, you are.
Yeah, okay. Good evening to all. We will have a short presentation on management of mild to moderate COVID in pregnancy. Best wishes from the city of Pune. And we will try to cover the rules, guidelines, and directives, categorization and course of COVID in pregnancy, any clinical stages of severity, how and where to manage, any guidance on investigation, treatment options. We will be mostly sharing our experience at Bharti Hospital regarding how we go ahead with mild to moderate COVID in pregnancy and try to give an idea about the ground reality, what we face here, a short slide on intrapartum care, discharge and follow-up of these patients, and how could be the way ahead and what lessons we learned. At Bharti Hospital, it's a tertiary care teaching referral center attached to our medical school, and we had more than 350 dedicated COVID beds with almost 60 to 70 ICU beds and follow a protocol-based management. The leaders of our team, which manage COVID, were the intensivists, and we have a DM in critical care medicine, and therefore we have got DM students and fellows and IDCSM fellows with a backup of medicine, pulmonologist, and a super team of anesthesiologists. And basically, with COVID going rampant, the whole institute took part in management of COVID, right from the seniors to juniors, residents, fellows, and interns. This will be a dedication to them also. With any COVID, what happens is we set up a fever OPD or a COVID testing center in our hospital. We have got a single building, and the administration has done an extraordinary good work to segregate the COVID and non-COVID amongst the patients. At the same time, we have undergone many publications with respect to COVID, and the hospital, medicine, pediatrics, and OBGYN have got a few publications. A department has got its publication, and we will share the results with you as the presentation goes ahead. Basically, ICMR categorization that is given in all guidelines mentioned as A, B, and C. And importantly, we have to note that pregnant lady comes by default in B. So for normal patients, A stands for mild disease, B for moderate, C for severe or red flag signs. Whereas as per ICMR, pregnancy being an immunocompromised state and many things, it falls directly into B. Importantly, this categorization has to be reassessed every 24 to 48 hours to really know and have an change into it. So what we require for our management is this: the clinical stages of severity, category, pregnancy category B is then divided into B1 and B2. B1 is asymptomatic and B2 is pregnant woman with influenza-like symptoms, which can be fever, rhinitis and everything. And category C is a different set that we are not going to discuss today about severe COVID. Importantly, again, this categorization has to be reassessed every 24 to 48 hours because the patient can shift from B1 to B2 and from B2 to C. At the same time, they can be from C to B2 and B1 and go home. What we require to know for today is the severity. What can be mild to moderate? So it's going to be no breathlessness or hypoxia, and moderate are going to be those patients who are having dyspnea and hypoxia and a respiratory rate between less than 30 SpO2, 91 to 94% on room air, or they can be having fever and cough. Severe, we are going to discuss today. I hope there was the last week a CME there in NMOGS on COVID, which must have covered most of the aspects. So we will try to have a experience sharing in this scenario. So up to date and many other things give all symptoms of COVID: cough, fever, myalgia, headache, dyspnea, sore throat, diarrhea, nausea, vomiting, anosmia, ageusia, rhinorrhea, chills, and everything which are into there. More importantly, the symptomatology doesn't differ much into pregnant and non-pregnant women. So cough, headache, muscle aches, fever, sore throat, and everything appear to be more or less same. So there is no symptom which is unique to pregnancy, which can lead to we saying that it is can be COVID as such. WHO, importantly, you have to understand that some of the clinical manifestations of COVID, they overlap with the symptomatology of normal pregnancy, like fatigue, shortness of breath, nasal congestion, nausea, and vomiting does required to be addressed very sensibly regarding a proper evaluation of these symptoms, and this should be considered in any afebrile symptomatic pregnant patients. So with these symptoms, you have to have a threshold regarding assess the patient and take a call Any patient who has got symptoms requires testing, and as per testing, then we follow the further algorithm. So why do we understand this course in pregnancy? We'll have a few short slides because a good saying goes that a searchlight cannot be used effectively without a thorough knowledge of the territory. So unless we understand the basics about COVID, pregnancy, and how does COVID affects pregnancy, then we are not in a good position to counsel this woman. And counseling, out of all these things, plays a very important role when we manage asymptomatic or mild to moderate. So before or as we counsel patients, we require to have a short summary of what happens in pregnancy. Importantly, pregnancy does not increase the susceptibility to COVID, but appears to worsen the clinical course of COVID as compared to non-pregnant females of the same age. 90% infected pregnant women do recover without hospitalization and everything. And the same is being followed in our institute. We have got more than 90% do require home isolation, and they do recover uneventfully. But importantly, rapid clinical deterioration may occur. At the same time, we require to understand that symptomatic pregnant women appear to be at an increased risk of severe disease as compared to symptomatic non-pregnant females of reproductive age group. At the same time, you have to understand the risk factors for severe disease are older women. They are most commonly having infertility, IVF conceptions, obesity, pre-existing medical disorders. More importantly, hypertension or preeclampsia and diabetes are an important confounding factor. Out of all the patients that we found who had severe COVID, most of them had either of these conditions present. And maternal mortality in COVID is that way less. 0.4 to 0.8 is the reported. Luckily, in our institute, we did not have any maternal mortality during this first or second COVID wave per se. Perinatal issues, in short, there is no risk in the risk of miscarriage, no increased risk in miscarriage or perinatal anomalies. Stillbirth report rate is 0.4 to 6.6, which is common natural average. Preterm labor and CS section rates are increased in moderate to severe COVID. Fever and hypoxia may lead to risk of preterm labor, PRM, and abnormal heart rate pattern. Fetal growth restriction becomes a challenging issue which can occur because of placental insufficiency, maternal vascular malperfusion, and villus inflammation. Vertical transmission, though there are reported sporadic cases, is still not documented. So with this background about the course in pregnancy and parental issues, I think we will be in a better position to counsel these women. So what happens with asymptomatic and mild cases are the government guidelines say that can be avoided home care. Dietary advice, avoidance of total bed rest must be emphasized. We'll come to it. Iron, folic acid, calcium are to be given, and they can report to the healthcare facility if they become symptomatic or have a fall. They should be doing the walk test. So, we have evolved from the first wave to the second wave and maybe in third wave. So initially we were doing a 3-minute walk test. Now we are committed to 6-minute walk test, but pregnancy, asking a pregnant woman to walk for 6 minutes around doesn't seem suitable. She can take 40 steps and measure the SpO2. If the fall is more than 3% from the baseline, then she should report to the healthcare facility for it. What we mean by home care is, 90% are suitable for home isolation. This was different from the first wave. In first wave, we're not very sure about home isolation, and for many women, we're giving them a choice: either go for home isolation or admission. Whereas in the second wave, we are trying to promote as much as women for home isolation with a proper follow-up. We have to advise them or counsel them for proper hydration and adequate rest. At the same time, we have to counsel them for frequent ambulation. Pregnancy being a prothrombotic state and COVID and thrombosis is an emerging issue. So adequate rest with frequent ambulation requires to be stressed for this woman. Monitoring of pulse, respiratory rate, SpO2, the walk test as we discussed. Follow up closely for the progression of disease. Instructions for infection control for the family members requires to be addressed. Symptom management that we do for all patients, we have to mention them and advise them about the warning symptoms, when to report, or the red flag signs when they have to report to a COVID care center, and the obstetric follow-up for patients depends upon it. Whether you should come into it, it depends upon gestational age. So if the patient is entering gestational age, then we advise her to follow up in the COVID center where we have an obstetric examination done and advise her accordingly. So home isolation insists, should the woman visit the COVID center or can there be just a telephonic consultation? The guidelines mention physical visit with detailed assessment of past records through general examination. And what happens is a patient comes COVID positive at a practitioner, at the obstetrician, and then he or she tries to refer the patient to a COVID center. And even there is a helpline, the COVID center cannot really assess what exactly is the patient condition. And therefore, the government guidelines are more like a blanket. So they advise, if possible, the patient can always come for a physical visit, which is again good. What about video call and telemedicine? Now, as in our clinical practice, we come to know patients do many times underplay or overplay symptoms. So with just a telephonic call, you may miss the symptoms into it. So if you're not very sure about it, the patient can be always referred to a COVID center for at least having an evaluation, and let the COVID center take a call regarding home isolation or into it. Just advising home isolation on a telephone might be a little bit risky. Fine. And then assess the no comorbid condition or obstetric complication. Pregnancy demands prioritization. And therefore, the scenario at COVID center or through OPD becomes different. Though we tried our level best, suppose a pregnant patient comes into the COVID center for RT-PCR examination, the security knows it's all well. So he tells or gives a proper management for the patient, and he takes her faster through all these cubicles and get her assessed. But still, right now COVID has reduced significantly less, but 2 to 3 weeks back, it was havoc in the COVID center. So what happens now? An obstetrician who gets a positive report with COVID, he or she then refers the patient to a pure OPD at Bharti hospital, and then the patient comes to the pure OPD that we mentioned. It's like a stopgap arrangement. You have to understand this about it. COVID now becoming a temporary condition. Every government facility is only given to giving something stopgap for some 1 year, and after 1 year we may again follow back with things. So this patient comes to this room number 1 that we have mentioned, and there's a small window there through which the hand goes inside, and they take the pulse, BP, SpO2, and this barrier always remains there. If the patient has got SpO2 of more than 94%, she goes to the triage. She did not go to the counter 2 for home isolation. She goes to triage at 94%. They assess her, oxygenate her, give a walk test, and then take a call on admission. If her SpO2 is more than 94%, she goes to this room number, so-called 2A, 2B. Now again, there's a small window there, a small hitch, wherein the patient is counseled, talked into it, and the room 4 that you see in the middle gets a room there where there are curtains, and there is a space provided for obstetric examination. Now, with this, it's always a chaos at most COVID centers. So the all time given for counseling of this pregnant woman can be maybe 10, maximum 15 minutes, because the resident, the consultant sitting there required to see a barrage of patients. In a high time, we were having a OPD of 300 in this COVID days, and a pregnant woman also being there creates lots of chaos. So even if there is a need to give time to her, the obstetrician or the consultant or the resident in COVID center may not give her that time which she demands and which she needs for her symptoms. So this home isolation handout comes handy. We hand it over to the patient, counsel her, give her time, give a prescription, and advise her to follow. And this helps us. So any handout now is going to be important for managing these patients. And then importantly, what can be the role of the primary care obstetrician or in these patients who are asymptomatic or mild? If you get a positive report, then the patient lands up in a COVID center. Now, importantly, for the obstetrician, and what always happens, their role starts with diagnosis and referral. Many times, patients who are referred from non-obstetric hospitals or OPDs, their role just ends when they refer the patient to COVID center. Whereas obstetricians do understand that the role, in fact, starts with diagnosis and referral. The main challenge that occurs at our end or at the obstetrician end is denial. A patient who is totally asymptomatic just denies that she has got COVID, and this denial requires to be addressed. Many times, a patient repeats a test without our knowledge. Example, a test done in an institute, she repeats in a government hospital. A test done in government hospital, she tends to go for an institute or a repeat laboratory. And this repeat testing is not advisable. And you require to convince this patient about this. A report, once it comes positive, it has to be taken as positive, where it be a rapid antigen or a RT-PCR. But this requires time. And this denial is very important to address. We have to give time and have patience with this woman. And this though we have got a good heart at the COVID center, we may not be able to give this time and patience. And treating obstetrician or the referral doctor knows what is at stake. So the patient and the doctor know how they have gone through this pregnancy. The anxiety and fear are better addressed by these referring doctors, and they have to be a part of management, which usually occurs. So we are in touch with them telephonically, giving them a feedback about what is happening to the patient, and then it becomes good. And importantly, this post-COVID follow-up. Once suppose the patient who is not far away from term and she gets management in the COVID center, she is bound to go back to the referring obstetrician. And that is where the patient ball lies back into the report. And this post-COVID follow-up, depression and syndrome is a challenge in itself. So this has to be kept into mind that after 14, 17 days, the patient is bound most of the time to follow up with the primary care obstetrician. For patients who are having moderate symptoms, so it comes into category B2 of ICMR, and we admit them in these COVID wards. Right? And these are pretty good wards. They are very airy, properly ventilated, maintained wards into it, and the patient can be there and be on oxygen and the drugs. So admission in dedicated COVID center, oxygen for these patients as per requirement. The patient in triage itself, she gets a proper requirement of oxygen, and then the triage people inform the ward that this patient has come, she is requiring this much liters of oxygen, and then they admit as per the ward into it. And routine medications, paracetamol, antitussives, vitamin C, and zinc, pregnancy supplementations are given. Diet takes a challenge in COVID wards. Fine. Now, COVID ward atmosphere is different. So, from our experience, we can tell it becomes a challenge for the patient. A pregnant woman, as we talk, demands prioritization. It's a sensitive issue, and the COVID ward becomes generalized. Now, the ANC patients are not that high to have a separate COVID ward into it. Fine, we tried every option into it. Initially, we tried to have a separate COVID ward, but the indoor were less, and therefore that ward took care with other female patients. And then currently, we are admitting patients in female wards, which are not only for ANC patients or PNC patients, and it differs from institute to institute, and that takes a backspace in COVID management in wards, because though a diet is supplied, a dietitian takes call, the patient is not in a good position into it. Though we try to advise her, the diet given by the hospital is nutritious and the diet is sent by the patient's relative, but it takes an emotional thing. And baseline laboratory test is what we discuss in the next slide. So what we do for now, we are dealing with moderate COVID. Mild and asymptomatic are done with home isolation. Now indoor admissions. So we do a CBC, BSL, serum electrolytes, LFTs and RFTs baseline for all women who are having moderate COVID. ECG, if there is going to be tachycardia, we go for an ECG read into it. Then we send a pro-inflammatory markers, which are CRP, ferritin and D-dimer. Procalcitonin comes into picture for severe cases. We don't send procalcitonin for each and every patient. We individualize it. X-ray, which can be done if they are not responding, cough is there still persistent. HRCT is that way very rarely needed if there is very severe worsening into it. And HRCT can be done in pregnancy. The radiation dose doesn't cause any harmful effect to the fetus after 20 weeks as such, but very rarely needed. Books say it can be done, but in our experience, we have very rarely needed HRCT. Those patients who required this required termination of pregnancy. So once the baby is out and the patient becomes a PNC, and then the HRCT was performed. So antenatal requirement for HRCT in our observation was less, and repeat markers are done as per the patient's condition in 48 to 72 hours, and then we go ahead. Monitoring is protocol based. So the guidelines which we follow: pulse rate, ECG, RR, SpO2, and then the same things are used for mild, moderate, and severe. And this is what is again given by the ICMR. That is what we follow into it. The cutoff levels for inflammatory markers, I think the last week also the speaker had mentioned about it. The normal values and D-dimer, ferritin, LDH request to be kept into mind. D-dimer is still raised in pregnancy. Important, the range is very huge. Suppose from 550 to 3000, it's a huge range for normalcy. To say regarding what is normal, what is abnormal, and the CRP values and ferritin. Importantly, we chase the oxygen requirement rather than chasing the pro-inflammatory markers. So we do repeat them, and they do give us a guideline. But rather than chasing D-dimer, CRPs, and ferritin, we chase oxygenation and the oxygen requirement. But the values required to be kept in mind when we deal with these patients. Coming to steroid trigger, fine. What we give is dexamethasone 8 milligram OD for 10 days. Fine, that's period as a protocol-based management. Other option becomes methylprednisolone IV followed by oral, but 10 days. So this is what we are following it, and most of the guidelines that the intensivist, the medicine people, and the BJV guidelines, and even accurate mention 10 days. Fine, and the difference will come to accordingly how physicians differ and intensivists differ in their management. Fine. In patients who are having only cough and they are not requiring any oxygen requirement, we do advise them budesonide. So it comes as a multi-dose inhaler, 800 milligram BID. Importantly, with budesonide, you have to advise them a proper oral hygiene and gargles. So saline gargles or betadine gargles have to be used, because then this drug sticks to the pharyngeal walls and the palate, and then with currently mucormycosis putting its head out, we have to be very sure about it. No need to explain that sugars have to be monitored in patients who are there on steroids. Heparin trigger. Fine. So heparin trigger is required for patients who are having category B2 and C. Importantly, you can use enoxaparin, that is low molecular heparin, or unfractionated heparin. Importantly, you have to give them a therapeutic dose. So there is no role of giving them any prophylactic dose of heparin. So if the patient requires heparin, then she requires a therapeutic dose. And what we give is unfractionated heparin 500 units BD, or enoxaparin 40 to 60 depending upon the patient's weight BD. Fine. Books and many studies differ with respect to doses and everything, but again, most of the studies and intensive guidelines mention a therapeutic dose. So understand a therapeutic dose, what is it and how we go ahead. Heparin, how long to given? It is given till there is an oxygen requirement, and once the oxygen requirement is reduced, we stop heparin. Fine. Higher doses are required in critically ill women or class category 3, and which are having high D-dimer levels. Then monitoring of platelet and APT is required if the dose really goes out of hand. And in patients who are having raised D-dimer, preeclampsia, who might be already on ecosprin, or those whom you think can be a high risk factor for thromboprophylaxis, they can be started on ecosprin 150 milligram if the D-dimer is high. But heparin till oxygen requirement is what we are following. And then we come to this drug, which is really making lots of noises, is remdesivir. Fine. It's a novel nucleotide analog, and it is effective against COVID, and it is also effective since SARS and MERS. So this drug is not unique to COVID. It was utilized in the prior pandemics also, during the SARS pandemic and the MERS pandemic. It is reported to be, it is used without any reported fetal toxicity in pregnant women, and also in Ebola patients and Marburg, and used in severe disease. Right? And all randomized controlled trial with COVID have excluded pregnant and breastfeeding women, but it is properly safe. Only thing is you have to be judicious about its use. Right? So moderate COVID requirement oxygen with inflammatory markers, you can individualize and start it. The earlier, the better. Dose is universal 200 milligram IV on day 1, and followed by 100 milligrams IV daily for 4 days. And issue is about availability and effectivity. It's a huge challenge. Fine. 2 to 3 weeks back, what we were feeling was, the drug was just not available to open market, and we had to send an application. It was only given to hospital pharmacies by Indian method. So the hospital has to send a requirement to the municipal corporation, and they have to send vials. Some days the vials used to come, some days the vial doesn't come. If the vial comes, they are less than what we are sent for. Then we have to prioritize the patient, whom to give first, whom to give last. So availability and effectivity is into it. And many ICU books. So we are referring here an ICU book, which we were referring for our fellowships in high-risk pregnancy and critical care in obstetrics, which mentions like a drug. If a drug is like that, all those who drink this remedy will recover, except those in whom it does not help, who will die. Therefore, it is obvious that it fails only in incurable disease. So you have to understand and be judicious about availability and effectivity. And this is a common prescription chart that we are using in our hospital for a COVID patient. Fine. I have particularly avoided discussing individual patients and some patients and what lessons we learn, but this is how it goes. Fine. So Limsi, Bicozing, dexamethasone, 8 milligram IV. So unfortunately, heparin 5000 BID. Remdesivir was given on the first day. And what happens to the patient? Though I have put for this slide, the first dose was available. Second dose, the sister signs not available. Third day, not available. Fourth day, it was available, and so it goes. So though it's an important drug, let's not overemphasize its use. You have to be judicious about it. And though it has its effective, we are over relying on a drug like remdesivir. Pantotrin, Chelcal, and other drugs are routine OBGYN prescriptions. What about other drugs? Doxycycline, ivermectin, baricitinib, convalescent plasma, abiprubart, and colchicine, oseltamivir are not utilized in as such, and they are not advisable in pregnancy. So, and we are not talking about tocilizumab because it doesn't come into mild to moderate thing. At the same time, if you can remember the last slide, there was no antibiotic given for these patients. Fine, there was no citrine, no azithromycin. So you have to be judicious about these drugs, and that is where the protocol comes into picture. And it is always better to have a proper hospital protocols for this management, so that we have got an all on the same floor for this management. Fine. So we don't do antibiotics, no ivermectin, anything in our hospital. And this is what the guidelines worldwide mention. Few studies are there which are pros and cons, but still we stuck to the majority of guidelines. Fine. Oseltamivir was given the first wave. Fine. There we were not sure about whether it was COVID or not. So any fever in pregnancy in the first wave, they were putting on oseltamivir. But currently, we are testing all symptomatic women. It comes RT-PCR positive. There is no need of starting any oseltamivir for these patients and the drug. And we are not dealing with non-pregnant women. Therefore, we don't talk about these drugs in pregnancy. Timing of delivery is crucial. It becomes debatable regarding when to deliver these patients or not. So it is individualized based on maternal status, concurrent disorder, gestation age. It's a shared decision making with the obstetrician, patient, family, and the medicine and intensivist if they are severe patients. For asymptomatic women, at 39 weeks, you have to think of this option that they can deliver early before they worsen. Now, if you see these slides of COVID, usually a patient who is destined to have mild to moderate disease, it starts from asymptomatic to mild to moderate to severe. Therefore, the patient may go on worsening. So take a judicial decision at term 39 weeks and more. You may think of delivering with the proper bishops and everything, just not the weeks and COVID, but do think of this option, because we have got many cases and we had many discussions in NMOGS also regarding when to deliver and not. Fine. So individual decision, early and late as per the clinical scenario. Labor as such, we test all women in labor. Early or late is what we discuss. Fine. And there are many things into it. Last week also somebody posted many things in our group regarding should we intervene with the patient of IUD, should we wait for the internal markers to reduce, or should we wait for a week into it, nothing can happen, and many times the patient just go into spontaneous labor and deliver. So things differ from patient to patient. There cannot be a rule of thumb into it, but be judicious about it. Fine. And what has happened in our experience, there were many women who were referred to our COVID center at 37 weeks with a COVID positive report. That was done before an elective LSCS planned at 37 weeks. Fine. And at this stage into it, it becomes a challenge. Fine. At 37 weeks, we don't post patients for elective section, and these women referred to our COVID center with no symptoms at all. So we could just manage them at home isolation, and then we send them back to the referring doctor after 2 weeks, and then they underwent a section in their parent obstetric unit as such. Fine. Support patients in labor and delivery rooms becomes a challenge as itself. Choosing the route of delivery, should we go for a vaginal delivery or LSCS? We'll come to a few slides on it. Delayed cord clamping can be done. Skin to skin contact is advisable. Intervention has to be as per obstetric protocols. And these are our statistics. Fine. In wave 1 of COVID, we had almost 81% sections in 60 patients who had been COVID positive. Those were different days, fine, where COVID was a taboo, and patients challenge, and the whole system was very much new to it. And in the second wave in COVID, we have brought down the section rate to nearly 50%. So things are changing, things are evolving, and we are doing good every day. Neonatology becomes a challenge. It will be difficult to discuss in this forum. The infant has to be considered as a person under investigation. So what they do is, a woman who delivers or undergoes section, then the baby goes to NSU, the pediatrician and the neonatologist then take an RT-PCR sample, and then the baby is isolated. Guidelines mention breastfeeding. There has to be rooming in for this, or the patient can use express milk, but the ground reality is different. What happens now? This woman after delivery or section goes to the COVID center and the room that they prefer, and then the baby there cannot be really have this proper isolation and this into thing. And so end of the day, the guidelines mention proper rooming in, attendant can be there into it, but practically at the grassroots level, this doesn't happen. So it becomes very taxing. Usually a PNC mother, it's all tender loving care, many relatives, help, support is needed. And if she becomes COVID positive, things become really taxing to the woman, to the family, and no doubt to the obstetrician and the baby, of course. But guidelines differ, and this is what is being done. Fine. Post-COVID follow-up becomes a challenge because the patient then goes back to the obstetrician depending on day 14 to 17 after the symptoms or test positive. Individualized follow-up through telehealth or in person. Development of FGR is an issue which requires to be dealt with, and it has been seen with other SARS infection also. obstetric follow-up protocols, post-COVID syndrome and depression is a huge challenge. So this patient now goes to the primary obstetrician, and you have to be aware about these things, and they can be really challenging, especially the moderate COVID patients. Fine, mild to asymptomatic, they do well. But moderate COVID who require oxygen supplementation, they may not prefer the COVID center again for the proper or normal ANC follow-up, and they may choose to go back to the obstetrician, and they have to be well versed with this post-COVID syndrome management and depression. Fine. These are the recent guidelines which are available on the web, 22nd of April, which mentions about mild, moderate, severe disease. Let's not go into details. You can read about it and follow them into it. Overestimation and underestimation is what we are doing. The optimal approach is still uncertain. So these are mentioned in even good books and guidelines. Really, what exactly is to be done is really not known about in COVID. But there are things which we say hit early, hit hard, better early than late, overtreat the patients than undertreat these patients, and guidelines are ever changing. Fine, we have all gone through this, the guidelines, we have gone through running after hydroxychloroquine and to COVID being a taboo and referring patients right, left, center, advising all admissions to everything, and practical experience is different. Fine, and this drug cocktail, no, if you see any prescription from any other center, they give all possible drugs, oral steroids, and n number of drugs, which are then becomes indication of an exhausted healthcare system. Fine. If you look at the COVID centers, now I can vouch the intensivist, anesthesiologists, medicine people, residents, doctors, consultants are really overworked and exhausted. So, for a proper management, instead of having any big bags afterwards, why not you give this and why not? They tend to give every possible drug, and the patient lands up with having a drug cocktail, and this is what is happening at the ground reality. Fine. So patients, different physicians have got different opinions, and this comes by their experience. So physicians have seen lots of COVID complications in non-pregnancy, and they are becoming very much worried about it, and therefore they advise long-term anticoagulation into it. But guidelines differ, so you have to follow someone who know and a few good people who can make a difference in this management. Fine. So blanket approach doesn't work. Blanket physician doesn't work. My advice will be to search for a few good people, a few good physicians, a few good intensivists who will make life easier for you with respect to this, rather than going for blanketly physicians are prescribing this, blanketly intensivists are prescribing this. Fine. And serious illness has got no landlord. So this is what is mentioned again in ICU books, that a patient like illness like COVID, no? Then there's nothing like who will be the managing person, an intensivist, physician, anesthesiologist, pulmonologist. Many people come into picture, and then this is what we are learning from COVID regarding where exactly this disease falls into. Way ahead, diseases are becoming more virulent. So this is again strains are evolving. So families are affected with COVID. So once a pregnant woman comes positive, we have to be very much sure that there must be family members who are being positive for sure. So a virulent drug, airborne transmission, WHO is now saying it's not top, it's airborne is a challenge. Some say we have to live with COVID. So it becomes a challenge in itself. How are we going to live with COVID? Complications are going to occur. We are now having mucormycosis. We are thinking it's now going to affect younger age group pregnancy. And this study is there in the United States. So a private study which will really give us insight into what really is happening with pregnancy and COVID. There has to be dedicated COVID obstetric units for these patients, and take over of government hospitals. Mumbai is having Nair. Navi Mumbai is having done very good work. Pune, we tried to have few hospitals turning into total maternity units, but it's a challenge in itself. We require manpower and finance. So this dedication will help this patient. It will be a psychological relief for the patient also to be there with all ANCs who are mild, moderate, and into it. Severe have to be transferred to units. So dedicated COVID centers help a lot. This Nair hospital really did very good work with this thing. The patient is then amongst themselves, and COVID ward is depressing. So immunization for all pregnant women is what we are looking at. It will be going a long way. Fine. There are national registries. This is a Nair registry, and we have got the Foxy registry, but they are still very much underutilized to know really what is happening in COVID. Now we have to have a good registry. It's like eclampsia. We have got a eclampsia registry where we can quote the national statistics, but with COVID, we have to have a good registry to know what is really happening into it. Take home message, symptoms in COVID and pregnancy overlap. 90% do require home care. So for sure, this second wave, we dealt with lots of women who with home care and asymptomatic to mild cases, and we had a significant amount of ICU admissions and critical care, but they were having comorbidities, and preeclampsia was an important thing that requires to be just kept in mind. Mild to moderate to severe, so they can go into it from mild to moderate and moderate to severe, so they have to be reassessed every 40 to 72 hours, counseling plays an important role. So giving time to the patient is important. Nothing will beat this. And to know the course is going to be important, because then you can be in a better position to counsel. It has to be a symptomatic management, moderate indoor oxygen, heparin, steroids, remdesivir. Just don't over rely on a single drug. And even there's no remdesivir, be sure steroids and heparin are going to work with oxygen and a proper intensivist or a physician looking after along with and oxidation. So remdesivir is useful, but don't just over rely on these drugs. The ground lines are changing, and differently we came into different things, and there's a different ground reality. Individualized management with respect to severity, gestational age, any comorbid conditions and warning signs, and prepare for tomorrow. I think that should be the end of it. And a big thanks to a near and dear friend Santosh Jai for this opportunity, Dr. Sachin and Dr. Rahul and NMOGS. It's an honor to present this presentation in front of all of you. A big
thank you. Thank you, Dr. Aniket. I think it was absolutely, there was no question, I think, in anybody's mind how to manage the mild and moderate cases of COVID. So really, thank you for such a very wonderful, elaborate talk from you. Really, thank you. Okay, now we're going to the next talk. So I would like to invite our next speaker, Dr. Hitesh Bhatt, sir. Sir, at present, practicing at Andheri, Mumbai, he's a medical legal consultant, having 20 years of practice. He's a medical consultant at Vadia Maternity Hospital, Mumbai. He's a medical legal consultant at Central Railway Hospital, Mumbai. Sir is a partner in legal firm B&S Medical Legal Consultancies. He's a past chairman of Ethics and Medical Legal Committee, Foxy. Sir has authored a lot of books, but out of that, there's one main important is the consent in obs and gynae law doctors must know. And he has got an author website that is www.consentfordoctors.com. Sir is invited faculty for national and international talks, and he has got medical legal consultant to 80 hospitals all over the country. Sir, so a really warm welcome for this webinar of different strokes for the medical legal talk, sir. It's over to you.
Thank you for kind introduction, and I thank Rahul, Santosh, the entire NMOGS team for inviting me and allowing me to share my views with you all on the topic. Now, I always tell that whether it is a Hindi film or a conference, the law comes last. But in your practice, please keep law first, then you will be safe. So that thing should be kept in mind. And now, when I talk about PCPNDT, the topic given to me is about PCPNDT. And when I talk about PCPNDT, I start with a story which I have written years back. So there was a king and there was his kingdom. People were happy in his kingdom all around, but they had bad habit of throwing the garbage on the road. So that was age-old culture of that particular city. People used to throw the garbage on the road. And there were piles and piles of the garbage all around the city. And it was impossible for anybody to come out due to bad odor, which is coming out of that garbage. So people complained to the king. They said that, sir, do something, because this bad odor is very bad and it is impossible for us to come out of the houses. The king was very tense. How to change the age-old custom overnight? So he took advice of his wise ministers, as we have ministers today. The minister told him that, sir, you have not understood the problem. The problem is not the habit. The problem is the bad odor which is coming out of that garbage. So what you have to do is you have to mask that odor. And as we have people who are throwing garbage on the road, we are having the people who are selling perfume in the town. So ask all this perfume wala to sprinkle that perfume over the piles of the garbage, and that will mask the bad odor. And they made the first ever law of that time, Perfume Contribution Perfumes Neutral Distribution Technique Act. That was the PCPNDT Act of that time. So they made that act. And yeah, there is a disclaimer to this story that this is purely a work of fiction, and any resemblance to any law of the land, past or present, is merely a coincidence. So they made various forms, Form F, name of the perfume shop, who sprinkled it, where was it sprinkled, which was the fragrance. They made that form, but still people continued throwing the garbage. And it was impossible for all this perfume wala to control that. And there were more and more piles of garbage all across the city. Again, people complained that, sir, do something. In spite of the law in place, nothing is happening. The king got angry this time. He said, make the rules very strict and ask them to report online, ask them to fill the form, and those who are not filling the forms, put them behind the bar. So they started putting all the perfume wallas behind the bar. Friends, can you compare that story with present time? The decrease in the female birth rate, that is just the bad order which is coming out of the age-old customs which we have. Nobody is thinking about changing the custom. They are just making the laws stringent. And we are at that stage now. But whatever it is law of the land. And we have to follow the PCPNDT Act. And we have to stepwise follow the PCPNDT Act. Why? I will tell you in next slide. First of all, we must understand what is preconception and prenatal diagnostic techniques. Preconception and prenatal diagnostic technique includes two things: preconception and prenatal diagnostic procedure and preconception and prenatal diagnostic test. So technique includes both the things, procedures and test. What are the procedures? We all know sonography is a procedure, fetoscopy is a procedure, or taking sample of amniotic fluid, embryo, or blood, or any tissue, or fluid of pregnant woman or man before or after conception for sending it to laboratory for sex selection. That is called the prenatal diagnostic procedure. And prenatal diagnostic test means whatever sample you send to the laboratory, the analysis will be done and ultimately the result will be out. Even ultrasonography is a standalone test because you can immediately give the result after the ultrasonography. For that matter, even NIPT and PGD PGS also falls into this category. So these are all the things which is there within the ambit of the preconception and prenatal diagnostic techniques. After understanding this, and before understanding anything else in the law, I always tell that let us concentrate on section 23. Forget the section, but what it mentions, that is most important. What it says, any medical geneticist, gynecologist, or any person, or who is employed there, who contravenes any of the provision of this act or rule made thereunder. So they have used this word any person who contravenes any of the act or any of the rule made thereunder is liable to be punished for imprisonment of 3 years and 10,000 rupees fine for the first offense, and on subsequent conviction, the 5 years of imprisonment and 50,000 rupees fine. So it is very much important for us to understand that it is very much important for us to understand what are the rules and what are the provisions of the act, because otherwise the punishment is 3 years of imprisonment. Keep this in mind while you understand what I am telling you next. Also, it is said that the names will be given to the medical council for taking any appropriate auction just when the case is filed against you. So Foxy tried to challenge this any word in the court by this writ petition, but the Supreme Court said nothing doing. This will remain as it is, and we are at the stage now that this any word is still there, and we have to follow the entire act, and the punishment for not following any of the rules or any of the regulations made thereunder, we are liable for punishment of 3 years of imprisonment. Now, first thing is, do not work at a place which is not registered. So registration is compulsory. That is made compulsory under section 3. Forget the section. What is more important is to understand what I am telling you. If you do not follow this, the punishment is 3 years of imprisonment, because this is a part of the act. It says no medical geneticist, gynecologist, pediatrician, or registered medical practitioner shall conduct any procedure or prenatal diagnostic technique at a place which is not registered. And this is very much important. One radiologist, she took a job in Nashik at one center, and she joined. It was her first day, and on that day the center's license was lapsed, which she was not aware about. The appropriate authority came on second or third day of her joining the job. They sealed the center because the renewal was pending from the center side, and the case was filed against this girl also because she joined the job at a place which is not registered or which was not registered at that particular time. We are still dealing with that case. But this is what is the situation, and it is duty of the person taking the job also to see whether the person is having license or not. This is not there in any other law. If you sit in a taxi, you are not supposed to see whether the driver who is driving the taxi is having license or not. But here it is giving a duty on the person who is joining the job whether the owner of the place is having license or not. So this is very much important. Please keep in this thing in mind. And naturally, when you start a center, you must have a proper license. These are various categories under which you can register your facility: genetic counseling center, genetic clinic, genetic laboratory, ultrasound clinic, and imaging center. I request all the gynecologists who are having a place and a nursing home where the admission is possible to register under genetic clinic and not under ultrasound clinic. Ultrasound clinic is for those who are having only sonography center and they do not have any other facility. When you have a nursing home attached, you should go for genetic clinic. The fees for this category are same. So you can choose genetic clinic, and that there are many benefits to it. Now section 4 to 6. Why it is important to maintain proper documentation? That is mentioned in this. What is written? It is written that person conducting sonography on a pregnant woman shall keep complete record thereof in a clinic in such a manner as may be prescribed, and any deficiency or inaccuracy found therein shall amount to contravention of section 5 and section 6 of the act. That means, what is the section 5 and section 6? Let us see that. Section 5 means prohibition of communication of the sex of the fetus. That means communication of the sex of the fetus is prohibited, and contravention of section 5 means you have communicated the sex. So if you do not maintain record properly, it will be presumed that you have communicated the sex. And what is section 6? Section 6 says determination of the sex of the fetus is prohibited, and contravention of section 6 means you have determined the sex. So if you do not maintain records properly, it will be presumed that either you have communicated the sex or you have determined the sex. So we always wonder that form F में एक full stop नहीं किया, मेरा machine क्यों seal हो गया, या form F में एक जगह sign नहीं की, क्यों ये हो गया? It is there in the law. And also here they have mentioned the word any deficiency found therein. Any deficiency. Now this any word is very difficult word. What is any? Any can be anything. If you do not put a full stop, it is a deficiency. If you do not write the date, it is deficiency. If you do forget to mention sign at 2 places, it is deficiency. If you forget to mention date at 4 places, it is deficiency. So you have to write or they fill form F properly. That is what this law says. Otherwise, it will be presumed that you have conducted the sex determination or you have communicated the sex. So let us see what we have to do in form F. That leads us to that. Form F is changed in 2014 and now it is 27 column form. This is very much important. Still many centers are filling the old form. So we have to fill 27 column form. Again, in filling form F, there are 4 parts of form F. You call it section A, B, C, D. So section A is the name of the patient, the obstetric history, name of your center, registration number of the center, husband's name. All these things are there that can be filled by your staff. Then part D or section D, that contains 2 declarations, one by patient and another by the doctor. What is patient declaration? The patient declaration reads that, and that is covered under section rule 10(1)(a). What it says, the pregnant woman shall, before undergoing ultrasonographic image scanning, shall declare that she does not want to know the sex of the fetus. And that is why we have to take signature of pregnant lady before submitting her to sonography. I was a member of National Inspection and Monitoring Team, and we went at one place in Andhra Pradesh where That's one center was doing some almost 100 sonography in a month. They had all the forms properly filled, but our team member asked the doctor that where is the form of the lady on whom you are doing sonography right now. The doctor said we are taking signature afterwards, and they ordered to seal the machine, because rule 10(1)A says that you have to take this declaration before submitting patient for any of the test or ultrasonography. Now, if you do not follow rule 10, the punishment is 3 years of imprisonment. So you have to be very clear about this rule as well. So you have to fill Form F. As I have told you, Part A or Section A should be filled by the staff. Section D, patient signature should be taken. Then you have to fill Part B or Section B or Section C as per the procedure you are doing. If it is invasive procedure, you have to fill Part A, B, C, D, all four. If it is under sonographic guidance, and if it is only sonography, you have to fill Part A, B, and D. And after doing procedure or sonography, doctor will have to sign at two places, one at the end of Part B, and also in the declaration that while doing scanning, I have neither declared nor disclosed the sex of the fetus to anybody. That you can declare only after doing sonography. So doctor will have to put sign afterwards. So please keep these things in mind. So this is how Form F has to be filled. If you are doing any procedure, invasive procedure, under sonographic guidance, you have to fill Part A, B, C, D. If you are doing only NIPT, which is an invasive procedure, but not under sonographic guidance, you have to fill Part A, C, and D of Form F. Also, whenever you do any invasive procedure, you have to fill Form G, that is the consent form, which is given in PCP and DT Act. So this is about the documentation, which is very much important to keep properly. Otherwise, the punishment is 3 years of imprisonment. Rule 3 says that every practitioner has to practice only at a 2 clinic in one district. Now, when we apply to the appropriate authority in the same district for more number of centers, and if appropriate authority allows you, then it is his headache. So you are not very much, you should not be very much strict about it. You can apply and see if he is giving you permission or not. Also, the various high courts have given stay on this particular section of the PCP and DT Act. So person can have or can practice at more number of clinics in one district than more than 2. Though it is there in the rule at present, but it is challenged at various high courts. Now, intimation of change in employee, place, or equipment. This is very much important. I have seen, or we are fighting one case from a place near Nashik, that is Trambakeshwar. What happened there? The doctor shifted the machine from one place to another, and his car got in an accident, and there was a machine there which he was shifting from one place to another. So if you change the machine or if you replace the machine, you have to apply to the appropriate authority. If there is any change in the place, employee, or equipment, you have to inform the appropriate authority 30 days in advance. And this is also very much important. So we have to inform. There are many centers which are training centers, and there the students come for sonography training. Those centers are also under liability to inform the appropriate authority well in advance, at least 30 days in advance of such a change. So you have to give names of all the people who are coming to your center and who are going to handle the sonography machine, not for observation. Those names should be given to appropriate authority under Rule 13. If you do not follow Rule 13, the punishment is 3 years of imprisonment. Now, portability. There is a the appropriate authority says that you can't move the machine. You have to keep it in a fixed corner. This is not correct. The law for PCP and DT, portability under PCP and DT, it says portability is allowed in 2 conditions. One, portable machine being used within the premises it is registered. So whenever you register your clinic under genetic clinic, you give a map of your hospital or your nursing home or your shop, whatever you have. And that map or that entire place is registered under PCP and DT. So you can move your machine within that registered place. But If you add a flat or any area afterwards into the nursing home and you extend your nursing home, you have to inform your appropriate authority that you have extended the area, and then only you can shift the machine to that particular area. Also, the more portability is allowed when the machine is a part of mobile unit. That is for the unreached areas or hilly areas where medical facilities are scarce, and government wants to provide medical facilities to those areas where you can take the machine in a car, and that particular van should have other facilities also, like pathology lab or operation theater. It should be a part of bouquet and not only a sonography facility. So that is what government has allowed. So for us, what is important is we can move the machine within the premises. That is what we have to understand. Do online reporting. Nowhere in the PCPNDT Act online reporting is mentioned. Rather, what is mentioned is if you are keeping reports on your hard as a soft copy, Rule 9/6 says this, in your computer or any other medium, it is important for you to keep the hard copy of such a record, and it should be authenticated. If you do not follow this rule, the punishment is 3 years of imprisonment. And that is why appropriate authority says you take the printout of the Form F. So you must have the hard copy if you are uploading the form online. Now, Rule 9 also mentions about the PNDT register. Now, what is PNDT register? It is simple a 5-column register. What are these 5 columns? That is also mentioned in the PCPNDT Act. Rule 9/1 says that every genetic counseling center, genetic laboratory, genetic clinic shall maintain a register showing in serial order. That means serial number is the first column, name of the patient is second column, address with phone number is the third column, name of the husband is the fourth column, and the first day on which they reported for such counseling procedure or test, that will be the fifth column. And here also appropriate authorities sometimes misinterpret this thing. They say the date on which they first reported for such procedure, counseling or test. Now, if I tell my patient to get sonography done today and she says, okay, doctor, kar dalo sonography, I have to write today's date. But if I do some procedure, suppose amniocentesis, if I counsel her today for amniocentesis, she comes after 5 days. Then I have to put today's date as the date on which she was counseled for the procedure. And the procedure date will be after 5 days. But appropriate authority sometimes says you have to write the first date when she came for OPD to you. Now, sometimes patient comes even since 18 years. I cannot go back and write the date when she first came to me, when she first time menstruated. But appropriate authorities are telling doctors to do that. And in law, there are only 2 options. Either you fight or you follow. So I always tell that you write, in that case, you write 2 dates. The first date on which she came for the first time and the date on which you have done the procedure or you have counseled for the procedure to the patient. So this is the correct law. If you do not follow this, if you do not have this register, then you are liable for punishment 3 years of imprisonment. You must have this register. Now, doing say ovulation study or any gynec sonography, that is not the part of PCPNDT. Why? Because the sex selection is not possible. Only the procedures where sex selection is possible, these procedures are under the ambit of PCPNDT Act. So if your appropriate authority asks you to mention in the register, maintain a separate register for other sonographies. But for PCPNDT procedures, always maintain a register separately and write only the procedures which are under the ambit of PCPNDT and don't mix the procedures in your register. Now, Rule 9 further on the documentation. All the case related records, form of consent, laboratory result, microscopic picture, sonographic plates or slides or recommendation letter shall be preserved. So what we say, what is important, you must have 4 things attached to your Form F. First, the referring sheet or the recommendation letter, what Rule 9/6 says. So you must have that particular thing as a first thing in your documentation. Then your Form F. Then any report you have given to the patient, copy of the report you have to attach. and sonographic plates. If you have given any picture or plates to the patient, you must have copy of it. Here the word or is used. That means if you are not giving the plates, if your machine is not capable to generate the sonographic plates, or you do not have printer, in that case you are not supposed to keep this thing. It is, if you are doing this, then you have to maintain it. So keep 4 things with each form and you staple it and maintain all the records for 2 years. Rule 9/8 says that we have to send complete report by the end of the by the end of the 5th day of the next month. So you have to report by the end of the 5th day of each month for the previous month, and this is very much important. And all the reports you have to record, you have to maintain for 2 years. So even if you are maintaining record online, I always tell that the printer, take the printout at the end of the month of all the forms you have submitted. Just check it whether it is matching with your register. The number of forms uploaded and number of forms mentioned in the register should be same, and you have to give one application to the appropriate authority. I call it a forwarding letter, that we have done this many sonographies, this many form have uploaded, kindly accept, and take their signature. If they do not sign, just mention that this forwarding letter was not accepted by the appropriate authority. Write the date and time and keep it in your record, but maintain a record. That will help you in a long way. My client got notice just 15 days back from Bangalore, where now they have said that you are not sending us the report. Actually, they are not taking the reports, but we are having this kind of letters with us, and we have presented all 2 years record to the appropriate authority, and he took back his notice. So you have to create documents that will prove or that will make your stand correct. Never take any advice from the appropriate authority orally. Ask him to give you anything in writing. Otherwise, they will change their stand, or if appropriate authority will change, he will say, "Maine to aisa bola hi nahi tha." So please take everything in writing from the appropriate authority. If he is not ready to write, you just tell him, "Sir, मैं लिख डालता हूँ, आप सिर्फ साइन कर दो. आप जो बोल रहे हो मैं लिख रहा हूँ, आप साइन कर दो." If he is still not signing, you just mention that this appropriate authority has told me to do this. This is the date, this is the time, and this is the place. Make the record so that you will remember who told you when. Put up a notice. And what notice you have to put? You have to put up a notice in your hospital, and it says sex determination is punishable offense, and we do not do sex determination here in 2 language. And keep a copy of PCP and DT Act in your premises. Why? Because there is rule 17. It says every genetic counseling center, genetic clinic, genetic laboratory, imaging centers, and ultrasound clinic shall prominently display on its premises a notice in English and in local language for the information of the public to the effect that disclosure of the sex of the fetus is prohibited. Now here they have not mentioned the size of the board, they have not mentioned the color of the font, they have not mentioned about anything. Only thing they have mentioned is it should be in a 2 language. One is English and one is local language. So you have to put a board. Still, many appropriate authorities insist that the board size should be 3/6 and the size of letter should be 1 inch. If your appropriate authority says that, you have to follow that. And at least one copy of act or rule should be available on the premises. They never say you have to attach it with your machine. It also doesn't say it should be in Marathi or in a local language. So when it comes to the rule, it has to be there available in the premises. It is not mandatory to attach it with the machine. Many appropriate authorities says you have to hang it with the machine trolley. It is not so. It is not mentioned in the law. So you have to follow the law, what is written in the law. And if you are doing exactly what is there in the law, nobody can give you any notice, or even if the notice is served, you will have successful outcome. Rule 18. This is again mentioned in Rule 18/8. The person or the people who are working in the genetic clinic, genetic counseling center, genetic laboratory has to display his or her name and designation prominently on the dress worn by him. That means you have to display, you have to put a nameplate with the designation. This is very much important. Nowhere the word apron is mentioned. And I had an argument with the state appropriate authority of the Rajasthan when I was medical legal committee chairperson of the FOXI. We were at Jaipur, and on the stage, Mr. Naveen Jain was there. He was state appropriate authority of the Rajasthan at that time. He gave notice to 150 centers in one day, and one of the contention was doctors were not wearing aprons. And I told him that, sir, nowhere in the PCPNDT Act the word apron is mentioned. He said, I will show you. And he showed me this. He said, see, it is mentioned that the person has to display his or her name and designation prominently on the dress worn by him. And I logically concluded, he said it. He said, I logically concluded that doctors wear apron. So apron should be there. I said, sir, I will give you better logic. What is written here? He has to display his name and designation prominently on the dress worn by him. That means he should be wearing something. A shirt can be a dress, a t-shirt can be a dress, a trouser can be a dress. As long as he is not naked, he is justified. I said that. Then he understood what I am trying to tell him. He said, okay, I will insist on nameplate only. So sometimes you have to argue with the appropriate authority, but you must have the nameplate with the designation. Apron is not mandatory by law. You have to remember dates. What are the dates? Application for renewal. The law says you have to apply 30 days in advance before the expiry of the PCPNDT license. So you have to apply 30 days in advance for the renewal. And every change, as I told you before, every change you have to intimate 30 days in advance of the employee, of the equipment, of the place, that means the address. If you are purchasing new machine, you have to ask appropriate authority. If your employees are changed, you have to inform appropriate authority. However, the High Court has given relief in cases where the employee suddenly goes. Suppose you have some dispute with the employee or your radiologist, and he says, I will not come from tomorrow. Now you cannot inform the appropriate authority 30 days in advance. In such cases, the High Court have said that you have to tell them or inform appropriate authority at least within 7 days in such cases. Now, do not do sex determination. That is what is most important aim of PCPNDT Act. Please do not do sex determination. Don't be casual about this act, because as I told you, for every rule and every regulation, the punishment is 3 years of imprisonment. And you have to follow this each and every rules and regulation in letter and spirit. Why it is so? Because otherwise there will be 3 years of imprisonment. And if you have time, if you have money, the jail is a good place. Like you will get food, you will get clothes, you will get some job, and you will get to meet your spouse every 15 days. So it is a good place. If you do not fear that, then you may not follow this. But otherwise, you have to follow this law strictly. Do not fear if you are not doing sex determination. I have seen so many cases we have dealt with. The courts are justified in giving judgment when the doctor has not done sex determination and the cases are presented properly. Do not admit something under pressure or under or due to negligence. I will elaborate this by giving last example of one case which we have dealt with. Some 10-15 years back, one doctor from Gujarat, he called me. What happened at his place? He had taken down the board during Diwali time. The board, sex determination is a crime, we do not do it. It was taken down and painting was going on in his hospital. The appropriate authority came on the day of Diwali to his place and he said board is not there. So he said, I will seal the machine. He sealed the machine, he went back. Then he himself told the doctor that, and he gave notice also to the doctor that the board was taken down for color and the board was not in place. Then he asked the that doctor that you pay me some bribe and I will and give an apology letter and I will open your machine. That doctor called me that night and he said that can I do this? I said, sir, please do not do it. We will fight this case, but do not give anything in writing and do not pay him. We will fight this case. But that particular doctor, he took advice from one lawyer also. Now his friend, his lawyer friend, he was dealing with RTO cases. Now in RTO, what is the general assumption? He told that lawyer that the board was not there, it was taken down and appropriate authority has given me notice. And he has asked me to pay some 10,000 or some 20,000 rupees and an apology letter. Should I do this? The lawyer said, okay, do it. It is not a big crime. Because what is there in the mind of the RTO advocate? If you do not have the name number plate on your vehicle, the punishment is 1,000 rupees fine, right? So he had that assumption. Board nahi hai to kya hoga? 1,000 rupees hoga. He said, okay, kar lo, koi problem nahi hai. So doctor wrote an apology letter that the board was taken down for Diwali work. I apologize. Henceforth, it will not happen. Kindly open my machine. The appropriate authority opened his machine. But appropriate authorities are also duty bound to put all this, his monthly activities report before the state advisory committee. So he put all this record before his advisory committee. Now, advisory committee is presided by the retired judge, one advocate, one NGO, one person from government medical college, one reputed person from the town. So they all said that you cannot open the machine. Your duty is to seal the machine and bring the case to us. We will decide. We are the authority. It is like police cannot release a thief. They have to present it before the judge. Judge will give him relief or judge will give him punishment. So the appropriate authority had already opened the machine. So the committee said, okay, since you have sealed the opened the machine, let it remain open, but file a case in the court. The case was filed. And after 10 years, case came on board. And his lawyer, that doctor's lawyer, argued in the court that the appropriate authority went on Diwali day. It was not an official day. The Panchnama is not correct because it is not signed by the two witnesses. He has not attached the photograph of the board which was taken down. So this Panchnama is wrong. So this doctor should be given relief. But the judge said that even if the Panchnama is wrong, I am having the affidavit made by the doctor, which is presented by the appropriate authority. It says that board was taken down. So I am giving him punishment because this whatever confession you have written or whatever maafinama you have written, that amounts to confession. And confession doesn't mean that you will get scot-free from any punishment. If I go to the judge and if I say that I murdered somebody, kindly excuse me, he will not. So judge said, I am giving him punishment and I'm considering his Panchnama, his affidavit and his this letter of apology, and I'm giving him punishment of 1 year. His lawyer said, sir, be considerate. He said, I can give it for 3 years. I'm giving only for 1 year. I'm already 66% considerate. Then that doctor called me again. That happened just 1 year back. He said, sir, now I've got 1 year of imprisonment. Kindly do something. I said, I told you on that day that please do not write such thing. He said, yes, but you did not tell me why it should not be written. I said, to give advice or to tell colleague what not to do, I don't charge. But to tell why not to do this, I charge. That is my profession. Then I took up his case. We went to the upper court. And what I argued there, I said, sir, even if the Panchnama is correct, we don't say it is wrong. It is correct. Even if the Panchnama is correct, even if his apology letter is correct, in which it is mentioned, in both this document, it is mentioned that board was taken down for Diwali work. In both that case, the board was there in the premises. Rule 17/1 says that board should be there on the premises. And then he got relief and the charges against him were dropped. So this is the importance. You have to, if ever you want to write something, please take some advice from the persons who are having knows about knowledge about the medical laws. All the lawyers are not well versed with the medical laws. The way I am not well versed about the laws related to land or Societies Act or the family laws, I am not well versed with those laws. Similarly, other lawyers are not well versed with the medical laws. So always take advice from somebody who knows the medical laws in depth. Do not reply to the notice on your own without any help from medical legal or legal person who is into medical laws. Do not think of leaving obstetric sonography because whatever you do, there is always a problem. We are heading towards a very legal society, or many laws are coming in. We are social. We are getting now more and more socialized. We are getting more and more harmonized. So laws will come. So please do not fear any law. And it is said that we do not get good laws to restrain bad people, but we do get good people to restrain bad laws. We are looking for some such good people to change this PCPNDT Act to make it more effective. So friends, do not fear. Just continue your journey, not only walking, but dancing like this baby. Thank you very much for patient hearing. Thank you.
Thank you, sir. It was a really eye-opener for everybody. As for every time, your talk is absolutely fine. So this time is also not the exception for that.
Thank you.
And with this, 1 minute. With this, we'd like to, now any questions, Dr. Rahul?
Sir has explained it so well. So
I don't think so there any scope of question to Dr. Hitesh, sir.
As usual, he has been very perfect and very appropriate and very correct.
And very studious also, studious. Sir always tell story. I really like to hear that story every time.
Law is a boring thing. You have to make it interesting, right?
Yes, sir. Yes, sir. So at the end, I would like to say thank you to the Blisson Healthcare who has sponsored for this webinar, all the faculty members who gave their valuable time and very nice talks, and obviously all the delegates who attended this, and very nice response for the YouTube prescription. This one also, today's webinar. And thanks to our NMOGS secretary, Mrs. Purva Sawant, for doing the back office work. Thank you everybody for joining this webinar and giving this response.
On behalf of NMOGS, we thank Dr. Sachin Lokhande for beautifully executing the program.
Thank you. Thank you, Santosh.
Thank you.
Thank you.
Yeah,
Thank you.
I think
Thank
we
you.
can leave the this.
Yes, yes, yes. Thank you very much.
Thank you. Thank you.